现在你在。
对啊，开上面
我声音尽量小声。真的音乐吗？
你就会俩狗，
有点。
是因为你噪音，
有点焦虑。
心经摸上后，
为什么你在家里？
对，就是觉得狼选这样。
不过就是讲一个太累了。但是
过了，但是还是，直播会议，哦，好。
那个叫个饮料。
我今天本来想说是要买个奶茶还是什么，
那么是饮料。
然后我就想说今天要早点来印资料，所以一路真走到学校了。然后想说午餐跟他确定之后，看要不要订个那个什么乌龙面还是什么太阳面。
Jaya Renung apa na? Renung tahu.
Renung
Anjo masukku.
不对，我有研究群成果，我有填呢。
就两个人做生意，容易的。人家邀请，还在问他一次。
Din, apa kamu tulis itu?
我在前面看到。
Good morning, Java. I'm just testing.
今天23分啊。
Hello, everybody. Good morning.
Good morning, Prof.
Morning, Prof.
Morning.
Morning, President Papa. Good morning.
滤镜哦，没盐。
Everybody needs testing. Prof Bambang, mikrofonnya mute, Prof.
Hello, good morning, Professor Vivian. How are you?
Good, good. Thank you, President Bambang. Yeah, good morning to everybody.
Thank you. Good morning.
Good morning, President. Good morning, Professor.
Yes, good morning, Java.
Professor Jafar, how are you?
Thank you. What time is it now in Indonesia?
Bu Ipeh, coba tes mic Ibu.
Cek tahun. Aman.
Kok belum muncul ya kameranya? Sebentar.
哎呀也早该去了。
Kamera saya sudah on.
Oh ya sudah ini.
拿着去啊？啊，不是到现在也没开，借口吧？开了。刚才稍微小小的看到。
再次进来。You will start 5 minutes later, right?
OK， 好，那我请他下去。宝贝， 我现在那个帮我找16病房9株，请他病人现在下去牙科王世雷师的门诊，还要下去用他牙齿应该要吧，因为我会诊王医师，王医师在现在。
没有，就最近的30分嘛。
就是然后说那个保险要很骗给他，这个就是已经是骗给他骗。
什么？那工厂？我现在错过了什么？
但在今有一通保险收益先给我存档。
我是不是都没收到啊？
没有什么。
你那边都有我的。
有啊，当然了，800元。
有拼错吗？我这边都没有，还是满的，信箱满的。我现在
我要换一个 email。
我现在那个停留在8月5号下午3点。
对啊，他们是一个。
那我跟小换一下那个信箱好了，换 Gmail 那个。
会漏电。这个啊，他说电子他存档，可是这个不就是
已经scan 了吗？
Ladies and gentlemen, we will start around 1 minute later.
印出来还是？
跟给他存的。你要一定问他哦。
Okay. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning, ladies and gentlemen. Ni hao. My name is Viva Damayati. It is always and precious chance for me to be your master of ceremony in this morning on Monday, 16th of August 2021 in our big event 2021 International Combined Healthcare in COVID-19 Patient collaboration between Universitas Muhammadiyah Kalimantan Timur and National Taipei University of Nursing and Health Science. First of all, let us say thanks to Allah Subhanahu wa Ta'ala who has been giving us mercy, guidance, happiness, and healthy. So we can attend and participate in this event without any obstacle until now. Praise and salutation upon to our Prophet Muhammad Sallallahu Alaihi Wasallam, the last messenger, the best figure of this universe, the person who was able to save us from Jahiliyah era to Lightning era. The Honorable Professor Bambang Setiaji as Rector of Universitas Muhammadiyah Kalimantan Timur, the Honorable Professor Sufang Vivianihu as President of National Taipei University of Nursing and Health Science, the Honorable all of speaker at our event today, Dr. Jafat Ali Zargar, Nurse Julmah Astuti, Associate Dr. Kaiwei Wang, and Dr. Adi Lukas Kurniawan. Once again, we thank you for the presence of Mr. and Mrs. lecturers and also students. Welcome to all participants of the conference present today. Ladies and gentlemen, before we begin this event, let us pray together. May God make this event beneficial for all of us, and this event can run smoothly and conductively. Start praying. Finish. We would like to invite to deliver her welcoming speech the President of National Taipei University of Nursing and Health Science, Professor Sufang Vivianwu. Please, time is yours. Ladies and gentlemen, please give a warm applause.
Ini dipanggil lagi deh, Bu.
We would like to invite to deliver her welcoming speech the President of National Taipei University of Nursing and Health Science, Professor Tufang Vivian Wu. Please, time is yours. Ladies and gentlemen, please a game of warm applause to Professor Tufang Vivian Wu.
Let me remind her to be online. Please pardon for a few minutes. Thank you.
Okay, never mind.
They're getting her to be online. She's occupied on the phone. Thank you. Sorry about all that.
Good morning, Professor Tufang Vivian Wu.
I'm sorry about the President Wu. She's actually very preoccupied at the moment. But Imama just had a discussion with me. We would like to have President Bambang to go first.
Okay.
Thank you.
We will change to the first speak is Rector of Universitas Muhammadiyah Kalimantan Timur. Okay. Okay. Please. It is now my dear pleasure to introduce the Rector of Universitas Muhammadiyah Kalimantan Timur, Professor Bambang Setiaji, and also we would like to request to officially open this conference to Professor Bambang Setiaji. Time is yours. Ladies and gentlemen, please give a warm applause to Professor Bambang Setiaji.
So, I first? Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
Good morning, everybody.
Good morning.
The Honorable Professor Vivian Bu, Professor Nurse, PhD, the President of National Taipei University of Nursing and Health Sciences, Honorable Ibu Dr. Hajah Nunung, the Dean of Nurse Faculty from University Muhammadiyah Kalimantan Timur.
Morning, Prof.
Good morning. The Honorable Dr. Jafat Ali Jagar, Research Department from NTUS, and then Ms. Nurse Julma, Lecturer of Universitas Muhammadiyah Kalimantan Timur, Associate Professor, Professor Kai Wei Wang, Professor Nurse PhD from National Taipei University, Nursing and Health Sciences, Dr. Adi Lukas Kurniawan from Research Development NTUNHS, the same from Indonesia, familiar name. Distinguished guests and gentlemen, good morning, everybody. Good morning, all of you. Thank you very much. And also to the committee who has successfully held the seminar. Thank you very much for all of you. As we know, now we face an easy situation about COVID-19 in the world and especially in Indonesia. All cases in the world now reach the 208 million people, and death cases until 4.3 million, and still 608 new cases a day. Among them from Indonesia, very high also, the highest country with 3.8 million cases, total cases, and 116,000 death cases. But now Indonesia much decreased from July, the new cases 49,000, and now still very high, but much decreased. Still 27,700,000, and death cases a day still 1,500. Taiwan is among the lowest countries with only 2 new cases, 2% new cases, and the highest cases only 10% in June this year, and only 510 cases in highest in Taiwan in June. Okay, in this case, Indonesia side can learn how to manage the COVID-19 in Taiwan. Especially, we can ask to our colleges from NTU, NHS, how to manage the cases and how to solve the situation. The seminar also would like to share about how to identify, to treat the comorbid cases, especially with relation with cardiovascular. I myself is alumni of COVID-19 cases. We say penyintas. We and family get the cases in July last month. Almost 3 weeks. I take we say isoman. Isoman is self isolation in house, in our house, not go out and not what we call communicate with the people. After 3 weeks, I feel better, but still positive when we check in the laboratory. After 4 weeks, I got negative signs. Alhamdulillah, and now we back to our society, our community, and our works office. About the comorbid, in Indonesia also we find many death cases in relation with diabetic, and then cardiovascular, and then high pressure blood. This is commonly we face to become penyebab itu about the causality of the death. I hope this seminar can propose some management, some maybe treatment to the health sciences and to the managerial hospital and also government. I'm very happy to this seminar. I would like to thank you to appreciate the delegation from Taiwan National Taipei University of Nursing and Health Sciences, especially to the President, Professor Vivian Wu, and all colleges there. I apologize if there is something mistake when our staff collaboration with you. Let me now to open officially this seminar, which say say Bismillah, in the name of God. We open the seminar. I hope the seminar is valuable to our people in Indonesia and Taiwan and also all of the world. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you to Rector of Universitas Muhammadiyah Kalimantan Timur, Professor Bambang Setiaji. Well, we would like to invite to deliver her welcoming speech the President of National Taipei University of Nursing and Health Science, Professor Supang Pipianiwu. Please, time is yours. Ladies and gentlemen, please give a warm applause to Professor Supang Pipianiwu.
Okay. Rector Bambang Setiaji, ladies and gentlemen, good morning. 大家好. Hello, semua. Yeah.
Hello.
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 Hello. Yeah, I'm Shufang Vivian, and great to see you here online. On behalf of National Taipei University of Nursing and Health Sciences, I would like to extend my sincere welcome to all of you. This is a bilateral online conference between our university in Taiwan and UMKT in Indonesia on the healthcare in COVID-19 patients. There are around maybe 800 to 900 students from UMKT campus of Indonesia, and maybe 70 to 80 participants from Taiwan, especially Taiwanese participants were professionals from over Taiwan, our school and hospital and institutions. On behalf of NTUN and School of Nursing, also as the former director of Research Center for Healthcare Industry Innovation, I do hope we can have plenty exchanges today, which might lead to potential collaborations in the future. Today, we are going to have 2 lectures and 2 forums hosted by researchers and professors from each side. As we are still in the midst pandemic, I think the care of general diseases has been themed with different perspectives and treated with different highlights. For example, it has been reported that there is greater comorbidity between the heart disease and respiratory complications as the result of COVID-19. COVID-19 can increase the risk of mortality for the patient with pre-existing heart disease. Our research center has made some effort to conduct research on COVID-19 data in Taiwan last 2 years. Cardiovascular disease, comorbidity exploration, and nutritional care. Besides, our School of Nursing will be sharing experiences of pediatric and family nursing with this topic. In recent years, our school have had a closer tie with universities from Indonesia. For example, we have signed an MOU with universities Brawijaya and held another online international webinar in July, just last month. Of course, our school has been to UMKT and will work more closely together. So today is very important for the international conference online. With the new southbound policy in Taiwan, we consider that it's a greater opportunity to share our expertise and research output along the way. Hopefully, Our lecture and forum can bring you something bountiful and refreshing. Finally, I hope you enjoy today's conference and thank you very much. Terima kasih.
Terima kasih.
Terima kasih.
Thank you so much for Professor Supang Vivianu. Okay, before we start to the next session, we will take photos. Please, for all participants to turn on camera, and I will continue. Okay, let's start. 1, 2, 3. Okay, one more picture. Okay, 1, 2, 3. Okay. Yeah. Thank you very much for President of NTU NHS and Rector of UMKT. Ladies and gentlemen, now we will start the first session of this international conference. We will present the theme cardiovascular disease as COVID-19 comorbid and sharing experience of nursing care for cardiovascular disease patient in Taiwan during COVID-19. Next, we invite the moderator from National Taipei University of Nursing and Health Science, Professor Dr. Kai Wei Wang Catherine Wang. Please, time is yours.
Thank you. First of all, hello to President Bambam and President Wu and all the participants in this wonderful virtual conference. My name is Kai Wei Catherine Wang. I would like to introduce our first presenter. The presenter's name is Dr. Java Alizgaga, assistant researcher who is currently working in the Research Center for Healthcare Industry Innovation, National Taipei University of Nursing and Health Sciences. He has a medical doctor degree and PhD in public health. His primary interest is cardiovascular morbidity and mortality and biomarker research. He is currently working on the epidemiology of infectious and non-infectious disease. And he's an excellent researcher and educator in this area. Let's welcome Dr. Java Alizgaga.
Thank you very much. Now you can see my PowerPoint slide, right?
Yeah.
Okay. Okay. I start my presentation. So I start with the title that would be the cardiovascular disease as COVID-19 comorbidities, sharing the experience of nursing care for cardiovascular disease patients in Taiwan during COVID-19. So I will briefly first going to review the disease itself. And after that, I will focus more on nursing care and other things that should be considered in the hospital setting. So I think everybody remember when this pandemic started. So on January 2020, the World Health Organization confirmed the evidence of human-to-human transmission in Wuhan. And on 30th that month, WHO Emergency Committee declared the COVID-19 outbreak as public health emergency. And it took 2 months that WHO declared the outbreak as a global pandemic. So you can see some months and some time lag in this declaration. And I remember when it was a serious issue in the world. I had a conference in Korea, so I was giving a lecture in Korea. So it was on February time. That time that was really the world just found out that it's going to be a difficult issue. National Health Institute, NIH, began the first clinical trial in the US for a potential COVID-19 treatment. And Am I clear?
Yeah, clear, sir.
Yes,
Okay, okay. And for the potential COVID-19 treatment and remdesivir and antiviral drug originally developed to treat Ebola that time. And after that, the FDA took steps to expand novel coronavirus testing to hospital, clinical, microbiology, and laboratories. And it took another month that WHO declares that COVID-19 is a pandemic with more than 100,000 cases and 4,000 deaths in 114 countries that time. And confirmed cases of COVID-19 topped to 1 million worldwide in such a short time as April 2nd. And April 10th, the global deaths due to this disease topped to 100,000. That you can see that in a couple of months, this pandemic impact lives of millions of people worldwide. And as the time I prepared my lecture, that 200 million cases, confirmed cases globally, has been announced, and you can see that the speed of the increase in this confirmed cases is really substantial. And until now, 4 million cases of these 200 millions has been announced as the mortality for this disease. And then you can see that as this disease has intermediate mortality rate, but because confirmed cases are really, really a huge number. So you can see death due to this pandemic should be really focused on. So we should focus more on critically ill patients that are more likely to have to be faced as the mortality events. I will talk a little bit about the virology and characteristics of SARS-CoV-2. That as the phylogenetic analysis showed that this new coronavirus shares close sequence and homology, and it was less genetically like SARS-CoV and MERS-CoV, sharing only 82% and 69% of the sequences. On February 11, 2020, the International Committee on Taxonomy of Viruses named this virus Severe Acute Respiratory Syndrome, or SARS-CoV-2. So SARS-CoV-2 is the name of this virus, and the disease that this virus causes is COVID-19, or coronavirus disease 19. So mode of transmission this virus is primarily transmitted by person-to-person contact through inhalation of inspired droplets generated when infected individuals cough, sneeze, or speak. So you can see that the main way that this virus transmits from a person to another person is through droplets, because droplets contain a lot of pathogens. So masks can really help in this matter. So countries that are the mask is mandatory and people really care about wearing a mask and they're not ashamed of that. So they show they tend to better confine this virus. And droplet transmission occurs when the larger particles, more than 5 micron, contains the infected agents, are released into the air. And this, if the droplet is big, so it makes sense that it doesn't travel that far. But the airborne particles are about the particles less than 5 microliters linger in the air for a longer time and drifts farther away than droplets and react and reach the respirable fraction of the lungs deeper than droplets. So they have more risk to make somebody sick. So in this picture,
Java, can you speak a little bit louder or closer to the mic?
Yeah. I will
Thank you.
pick the microphone up. I think now is better, right? So you can see that for droplets for more than 5 micrometers can only travel for a meter.
So the most important way of transmission is the droplet transmission, because it can carry enough viruses to make somebody sick. So if somebody is more than 1 meter from you, so it's not gonna like infect you very easily, especially if he or she is wearing a mask. For longer distances, it's like the airborne transmission comes to play. So longer range transmission is the time that the droplets that less than 5 micrometers can travel. So there are some reports about like and some concerns about like if somebody or infected person touches something, should I like avoid it like for a long time? So there were studies about this, and they found out that the viruses can like live outside of human body and like can be transferred to another person. Is like on the metal that it can last to 5 days. So we should be aware of this on the coins that we use, and using virtual currency in this way really helps. And on the wood, you can see that 4 to 5 days it can like go to the pores of the wood and stays there. So in the restaurants, you can see that countries that have regulations about like sanitization of tables, like on the kitchenware, would like have a better experience in this pandemic. Also glasses, 4 days. So you can see that on plastic, glasses, wood, metal, it can stay like for a longer time, and even for more than 5 days. So like sanitization really helps, especially in the hospital setting that there are some COVID patients. And you can see other surfaces, paper, gum, and latex, even latex gloves. So in the hospital that they have limited resources, because the nurses and doctors cannot like change their gloves patient by patient. So they will suffer from like transmission of this disease to other people. So we should be aware of this fact, as some medical procedures can be both aerosol and droplet generating, as a tracheal intubation and high flow oxygen therapy, tracheostomy, tube insertion, bronchoscopy, cough assist therapy, and transesophageal electrocardiography. As you can see, many like COVID patients are in need of intubation, and intubation is like a droplet and also aerosol generating procedure. So that room that the patient has been intubated, it should be sanitized and shouldn't be shared with others, especially other COVID patients. And the risk of nosocomial transmission of SARS-CoV in the hospital can be potentially high. And we can see that sometimes a patient goes to the hospital for like the better treatment or like for the further processing, and he or she will get the new variants of this virus. And this nosocomial infection really can deteriorate the health of the COVID-19 patients. And in the areas with aerosol generating procedures are commonly used as like ICU or the respiratory wards or operation rooms can be a very, very serious place that that coronavirus can linger in the air or like on the surfaces and like transmit to other people. So those places in the hospitals should be like highly focused. SARS-CoV-2 can persist on intimate surfaces for longer periods, even like up to 6 days, and viral transmission through infected fomites and self-inoculated can occur as a result of poor hand hygiene, inappropriate use of personal protective equipment, and frequent touching of contaminated objects and surfaces. And the mechanism of cellular entry and invasion is important, especially like when we want to like develop, when we want to develop some vaccines for this virus. The initial step of SARS-CoV SARS-CoV-2 infection involves a specific binding of the coronavirus S protein to the host cellular entry receptor, which is the human angiotensin converting enzyme, or ACE2, as located on the cell surfaces. A lot of cell types in the human body contain this. After the binding, the viral envelope proteins fuses to the whole cell membrane and enters the cytoplasm via the endosomal pathway. And the ACE2 receptor is located in several tissues and cell types in human, as most abundantly expressed in type 2 alveolar epithelial cells of the lung. So the lungs are the first place that this virus can attack, as the concentration of this kind of receptor is the highest there. And ACE2 has extensively biological function in health and disease that plays important roles in maintenance of blood pressure, regulation of circulating blood volume and electrolyte, also fluid homeostasis, and maintenance of vascular tone integrity. So you can see that as the virus enters a cell, it is through the ACE2, as you can see, like the most abundantly is located in the lung cells. And you can see that other tissues with this receptor are also susceptible to this disease. And there are some reports that saliva glands also have a lot of receptors like that. So as an alternative way of like diagnosis of COVID-19, saliva can also be used. Angiotensin 2 also stimulates the vascular smooth muscle growth, enhances the expression of cytokines involved in the mediating inflammation, active gene transcription of some proto-oncogenes, triggers the synthesis of collagen type 1 and 3 fibroblasts, leading to the thickening of vascular wall and myocardium. These pathology can explain the responses of human body to this COVID-19, as it can like develop heart failure. So SARS-CoV-2 binding to ACE2 causes the internalization of the virus receptors complex, which leads to ACE2 downregulation and disruption of the normal angiotensin 2 to ACE2 ratio. And the human respiratory passages are the main portal of entry. Upon inhalation of infected droplets, or even smaller droplets that contain like enough particles, the viral particles attach and bind the surface of the xylated epithelial cell lining in the upper respiratory airways. And the majority of patients may remain completely asymptomatic. Now it's like there are reports that the majority of patients are asymptomatic, but I remember as the disease started, it was mainly like having symptoms, but this asymptomatic is like the result of the gene mutations and like the new variants, and cough, fever, like body pain, like being tired all the time, and the mild immune response are like other kinds of viral infections are common during like COVID-19 disease. In approximately 20% of patients, infection will progress to severe disease as the virus and migrates down to the respiratory tract, and it can cause like the leakage into the bloodstream. So the time that virus like reaches the blood, it can like be a serious problem. So the percentage of people that getting like sick, very sick, and need hospitalization is up to 20% right now. As considerable proportion of patients with severe disease will manifest pulmonary involvement and characterized by hypoxia, dyspnea, and develop of bilateral infiltrate and diffuse alveolar injury with exudative and intestinal inflammation, which explains the purpose of administering anti-inflammatory drugs in COVID-19 to curb the hyperinflammatory response. So like the time that a patient comes to the hospital, if it's like it's critically ill, it really helps to see the lungs, to see how is the involvement of the lung, and it really proportionate to the severity of the disease. As we will like talk more about like the diagnostic test in COVID-19 later. Moderate to severe COVID can also trigger a widespread inflammation and immune response activation. Evidence of high levels of interleukin-6, 1 beta, interferon gamma inducible protein 10, and other inflammatory proteins that can be a target of like new research in this field. The main organ primarily affected by SARS-CoV-2 is the lungs. However, the most hospitalized patients with COVID-19 present with some degrees of cardiovascular involvement, which can range from mild to acute elevation of troponin, acute myocardial infarction, myocarditis, arrhythmias, acute exacerbation or heart failure, and thrombotic derangements. Early reports in Wuhan suggest that myocardial involvement in COVID-19 was common, with 12% of who presented early in the pandemic showing signs of acute cardiac injury. The mechanisms of how this COVID-19 attacks heart will be discussed later. As you can see, the risk factors of like the cardiac involvement, cardiovascular complications, would be like prior cardiovascular disease. So patients with the prior cardiovascular disease are more at risk. Immune activation of like very early immune activation is also a risk factor. Shock or metabolic disparity and coagulopathy and immobility of the patient or other risk factors. So it can cause arrhythmia, myocarditis, acute coronary syndrome, venous thromboembolism, and cardiogenic shock and heart failure. As you can see that all of these conditions are really critical and really serious in patients. And hypertension as like a common risk factor for a lot of disease can be also a risk factor here. Obesity, coronary artery disease, heart failure, diabetes, arrhythmias, like previous arrhythmias, COPD and asthma, and advanced age or other age-related disease. As you can see that all these risk factors have been put like in the checklist. If somebody wants to get vaccination, is like faster than others with one of these background disease. And the complications, acute cardiac injury, myocarditis, as I said, heart failure and arrhythmias, thrombotic complications, and ACS can be like cardiovascular complications, as I mentioned. At a cellular level, the direct viral infection and cardiotoxicity, oxidative cellular stress, and accelerated apoptosis of the cells, endothelial cell dysfunction, and infection of cardiac pericytis can be counted as like the cellular level involvement. And organ level involvement of the heart demands and supply mismatch, as I will just explain more on like heart failure. Effects are hypoxemia, impaired myocardial tissue perfusion, changes in local vascular tone and vasospasm, and drug-to-drug interaction favoring arrhythmias. And as systemic level, immune activation of T cell, cytokine release, disruption of normal angiotensin II, hyperstimulation of ROS pathway, changes in vascular tone, hypercoagulopathies, and viral infection-induced hyperdynamic state. As you can see that 3 levels all confirm the cardiac involvement of COVID-19. As at first, I will talk more about myocardial injury and myocarditis because it's very important complication of this disease. Myocardial injury is common among patients with COVID-19, as was demonstrated in 12 to 23% of patients in early reports. So you can see that a quarter of the patients can develop this, defined as the decline in ejection fraction and marked increase in levels of troponin 1. So as the patient is like is admitted to the hospital with a simple echocardiography, we can see the ejection fraction drop. And also with a routine test, we can test the troponin. And I suggest that troponin should be like the routine test of the patients that go for the admission in the hospital and diagnosed with the COVID-19. As I know, right now, it's like troponin is still not a routine test in the clinical setting. Myocardial injury was first reported and identified in initial cases of COVID-19 in China. And you can see this is the overview mechanisms of MI in the patients with coronavirus disease. So you can see that type 1 is the coronary plaque rupture. So if there is a plaque, there's already a plaque in the arteries, it is easier to rupture during this COVID-19 and cause type 1 myocardial injury. And so the patients with a higher risk of having more plaques in their arteries are more prone to this complication. Type 2 myocardial injury, or the type that causes by oxygen supply demand imbalance of type 2 myocardial injury, can cause this type. And you can see that although these two are the main types, the virus itself can directly be invasive to the heart tissue, and that you can see the pathology findings of some reports that have like spotted the viruses in the heart muscle itself. It's not very common during like the viral infection, but some invasive virus infections can directly invade the heart tissue. Stress cardiomyopathy also can cause, as you can see, that the infiltration of mediastin during this disease. As the other type can be inflammation-related injury, as the interleukin-1/6 TNF gamma is like TNF alpha is like the most like common inflammatory cytokines that can be tested to see if there's going to be inflammation-related injury that can target the heart. Acute coronary syndrome is also another manifestation of this disease. So right now, if somebody goes to the hospital with a chest pain, should also be like tested for COVID-19, especially in the settings that the country is having serious pandemic issues. So every patient should be considered as a COVID-19, especially with ACS, that is like the characterized by the myocardial ischemia that has the chest pain. Is when the heart goes through the ischemic phase. So there's always like a sharp pain that is radius to the left arm usually, and also other symptoms. Some people don't have like the chest pain. They have just like the shortness of breath, or even like milder symptoms show. So an EKG should be administered like abruptly. Albeit uncommon acute infections, particularly respiratory tract infections like pneumonia, bronchitis, and influenza, are associated with increased risk of ACS. So it can be caused by COVID-19 as well. The other serious complication would be heart failure, as the heart failure itself also complicates the clinical course of COVID, and a new diagnosis of acute heart failure in patients with COVID-19 is associated with a higher mortality rate. So if a patient is like hospitalized by the diagnosis of COVID-19, and after that it develops heart failure, it has a higher mortality rate. So should be ready for like intubation or other invasive involvement of like medical personnel. Development of heart failure is also common among patients with COVID-19. In a single site study, it even heart failure even developed in 23% of the patients who were hospitalized with COVID-19 during the course of treatment. It doesn't mean that like a quarter of the patients will develop heart failure. It means that quarter of the patients that are critically ill and has been hospitalized that surely had like some kinds of like background issues like diabetes and other risk factors can develop heart failure during this disease. You can see that increased oxygen demand also could cause ACS. It can also cause heart failure, and you can see that the main manifestation is lower ejection fraction. So echocardiography should also like, because it's a cheap procedure and many hospitals can like do it routinely, but as like the cardiac involvement wouldn't consider as like the main manifestation of this disease, it has been omitted from a lot of routine tests in the hospitals. Myocarditis also can cause heart failure. Stress cardiomyopathy, ischemia, or infarction that cause like pain should also be considered a risk factor for like heart failure. Cytokines release syndrome, that is like body will go through inflammatory process. Is also another risk factor. Elevated pulmonary pressures and venous thromboembolism can also develop heart failure. Reorganization of care delivery during the COVID-19 pandemic. Now I want to talk a little bit about the increased access to telemedicine and the things that we can do for heart failure patients, because they're critically ill and we are not really happy that hospitalized heart failure patients to increase their chance of getting nosocomial infection in the hospital. So we have to increase access to telemedicine for them, as not all of the heart failure patients going to develop COVID-19 disease. So we should like promote using of telemedicine in those patients, and they don't come to the hospital if it's not really necessary, because if they get COVID-19, it's really difficult to treat them. So reimbursements for telehealth services really helps, because many patients are really concerned about like the money that they should spend in the hospital. So because some of their medicine could be really expensive, so they need to be refilled. So they like to come to the hospital, and many hospitals going through like the crisis of this COVID-19. So during their stay in the hospital, even if they don't have any symptom, they might get it. So telemedicine should like really be promoted, especially for heart failure patients. And virtual check-ins and e-visits, e-consults, provision of services by physicians, advanced practice providers, and other care team members, and waiving of penalties against the providers of HIPAA, and as it is health insurance probability and accountability. So like the government and like the insurance institutes can really help in this part of the increased access to telemedicine. Adaptation to physical exam and laboratory data. Vital signs measured through home blood pressure cuffs, pulse oximeters, and scales. Virtual exams or jugular vein distension, peripheral edema, and because these are like the normal symptoms in heart failure patients. So we should like deal with all these symptoms and signs to be like recorded virtually and be reported to the physician. So the physician knows what is the condition of the patient, and if it's really necessary, like refer to the hospital. And assessments of electrolytes, INR, potential for increased role for pulmonary artery pressure monitoring. These are like very advanced like signs of these heart failure patients that can be accessed, can be recorded and monitored in a home-based system. And the other thing is changes in the procedural volume and care delivery, limited cardiac testing, including echo and stress testing. And this is for the time that the patient, heart failure patients goes to the hospital and has to be hospitalized. So we don't want the non-necessary echo testing, non-necessary tests. So the physician should like really balance between the real necessary like procedures and the things that can be omitted. Increased nursing, phlebotomy, and medication administration services at home. And we can like find some services that deliver the patients' medicines to their homes. And increased referrals to palliative care and hospitals, and deferral ICD and CRT, and limitations in titration of GDMTs also can be really like necessary for the guidelines that doctors and nurses should know about this. I will talk a little bit about the considerations in the COVID-19 patients with heart failure. As you can see, the acute heart failure in the initiation of guideline-directed medical therapy, a new onset systolic dysfunction secondary to myocarditis or a stress cardiomyopathy, and use of temporary mechanical circulation support in the limited cases, and management of recovery of systolic function. So we should be aware of this in the acute heart failure. And in the left ventricular assist device patients, the close monitoring of anticoagulation given risk of thrombosis. Like we should be aware of thrombosis in these patients because they are like more prone to this. And changes in the hemodynamics and right ventricular function with ARDS and sedation and proning. Virtual delivering site evaluation as like other kinds of heart failure should be considered in LVADs. Heart transplant recipients are like clearly having like more problem than other kinds of heart failures, and drug interactions should be like considered, and a temporary reduction in immunosuppression, and rule out co-infections before the heart transplant. And common therapeutic considerations can be continuation of ACI and ARBs, QTC interval monitoring, as it could be really serious, as some of the COVID-19 medications can cause QTC interval monitoring, as I will talk a little bit later. Prophylactic and therapeutic anticoagulation in hospitalized patients, as this can be like very useful for the heart failure patients. I witnessed that a lot of anticoagulation therapies has been administered to like non-heart failure patients, that it can cause like other side effects, as like this like excessive bleeding in normal patients. So we should be very careful that all these like considerations are about like heart failure patients and like critically ill patients, and we cannot like administer other prophylactic therapeutics as anticoagulations. It is like treating more than needed. So the patient might not die of COVID-19, but will die of like excessive bleeding if we don't consider, and we just give a lot of treatment to non-necessary patients. Social distancing maneuvers like frequent hand washing and self-quarantine for patients, and encouragement of telemedicine and establishment of inpatient providers as like other kinds of critically ill patients is also very important in these patients. So the other complication is arrhythmias and conduction disturbances. Although arrhythmias are not very uncommon even in viral infection, the causes of arrhythmias in COVID-19 are multifactorial and are a result of several host and pathogen related factors. Early reports in Wuhan showed that 7% of patients diagnosed with COVID can experience heart palpitation as like the simplest arrhythmias that you can see, and initial disease symptoms. Cardiac arrhythmias occur in an estimate of 2% to 30 of patients with COVID-19, and about 6% of them are malignant arrhythmias. And they are more prevalent in critically ill patients admitted to the intensive care. The mechanism and management of strategies in arrhythmias patients. The manifestations could be supraventricular tachycardia, arterial fibrillation or AF, arterial flutter, complete heart block, cardiac arrest. Some of these signs can be like diagnosed by a simple EKG. So we should administer, and it's a cheap procedure. So we should administer to almost all patients as a routine, like involvement. Polymorphic ventricular tachycardia, monomorphic ventricular tachycardia, and multifactorial ventricular tachycardia are the manifestations of COVID-19 in the arithmetic. Potential mechanisms of this arrhythmia could be higher, like as other involvement of heart involvement could be hypoxia, myocarditis, abnormal host immune response, myocardial ischemia, myocardial strain, electrolyte derangements, intravascular volume imbalances, and drug side effects. Drug side effects could be very serious, as like a lot of viral medications that has administered in like large doses can cause like arrhythmias. Management strategies could be generalized management as the treatment like all non-COVID critically ill patients, and a specialized management like considering in inherited arrhythmia syndrome and management of QTC interval prolongation. Cardiac drug interaction should be really considered in these patients. Optimized management could be minimizing exposure to the patients and the other team, and triaging EP procedures. So I gathered some studies that showing the risk ratio of the effect of hydroxychloroquine, like as it has been administered in large doses for the COVID-19, as it can cause QTCs like the Q interval prolongation in COVID-19 patient. And you can see that this systematic review had found the real meaningful results that really shows that this hydroxychloroquine can cause QTC prolongation. As you can see that it's up to 2. It's like the risk of prolongation in hydroxychloroquine use patients, even like 2 to 3, or even like some studies have been like more relative risk. The other medication that is like hydroxychloroquine plus azithromycin. I remember that azithromycin was because it's an antibiotic, but has been administered to a lot of patients, as it makes some sense, because like co-infection to other bacterial infection are really serious in COVID-19 patients. So their lung involvement will decrease if we use antibiotics. So it has been, now it's like almost a routine to like administer antiviral plus like antibiotics, especially azithromycin in the patients with COVID-19. But this combination can cause more serious QTC involvement and the prolongation of QT interval. As you can see that like the total confidence interval is like meaningful, and it doesn't contain 1. So it means that like overall, if you add azithromycin to hydroxychloroquine, it can cause QTC interval prolongation of the patient. So after that, we should be aware of the arrhythmias in the patients, especially the ones that have been on this combination therapy. The other complication of COVID-19 is thrombosis and clotting derangements. Reports of unexpectedly high numbers of patients with COVID who present with thrombotic pathogens such as pulmonary embolism, cerebrovascular complications, deep venous thrombosis, and massive disseminated transvascular coagulopathy, or DIC, is like very, very serious. So the clots are like going through all other organs. As prompt clinical to investigate whether disorders in clotting and thrombosis are associated with COVID-19 infection. As the mechanism of this coagulopathy and pathogenesis of thrombosis, we can see the risk factors can be very simple as like acute illness, bedridden. If you are like bedridden, if some patients have been bedridden for a while, so they have more tendency to be found clots in their bodies. And fever, diarrhea, sepsis, liver injuries, chronic kidney disease, COPD, heart failure, and malignancy can be counted as risk factors. And the homeostatic abnormalities, pulmonary microthrombi, intravenous coagulopathy, and myocardial injury, as cardiac biomarkers can also go up. And the platelets is like controversially up or down. D-dimer and PTs or FDPs should be checked. You can see that inflammatory response and endothelial dysfunction, superimposed infection as lymphopenia can be a risk factor also, as like increase of interleukin-6 or CRP is like the inflammatory proteins that can be also checked to like having to show like which patient is at high risk of like the coagulopathy. So the clinical outcomes could be venous thromboembolism or even myocardial infarction, because those clots will go and get stuck in the heart or lung. So it could cause real problems. The consideration for thrombotic disease for the patients, healthcare providers, and health systems and professional societies during this pandemic. Like patients hospitalized with COVID-19, the pharmacological VTE prophylaxis, unless contraindicated, should be started. Careful assessment of incident thrombotic events. Follow PT or INR. Like these are the routine tests for like the follow-up of these patients. Continuation of procedures anti-thrombotic therapy based on clinical conditions should also like be considered. These are like for the patients hospitalized with COVID. Patients without COVID or mild COVID or post-discharge from COVID, they should also continue their therapy unless otherwise. Extend VTE prophylaxis. They should take their medication. They shouldn't stop after they discharge. Home INR checks should also like help them without like referring to the hospital. They can check their INR. Encourage their home exercise, home treatment, and other kinds of like remote medicine. For the healthcare workers, proper use and conservation of protective equipment and outpatient televisits and minimal team structures reduce the contact with COVID-19 as other types of complications. Deferring elective procedures or those less certain to be beneficial for the patient. So if something is really not necessary, don't ask the patient to come to the hospital. Age comorbidity restrictions for the patient's visit also should be considered. For older patients, we should like more tending to use telemedicine and non-referral visits. Research priorities setting for the personnel, societies, funding agencies should be considered. Advocating for improved public knowledge and expedite funding or research in the thrombotic disease can also like help. These are like the society level, and the hospitals and the healthcare system should like provide telehealth, and in appropriate cases consider switching to like completely be remotely diagnosed and frequent disinfection of the patients. Negative pressure procedure rooms can also help, but these require more resources. Cancel or postpone elective procedures, like we don't want like the patients that can wait to be like exposed to the COVID-19 during this pandemic, and improve the knowledge of this disease about like other coronavirus patients. We can talk a little bit about the risk stratification of ACS and venous thrombosis with COVID-19 in low risk, high risk, and in low or intermediate risk ACS, and in high risk ACS. As you can see, in high risk ACS that have also high risk COVID-19, we should have the guideline directed medical therapy for ACS, and consider the emergent transthoracic echocardiogram. We should like know what's happening very urgently. An urgent or emergent angiopathy and intervention versus systemic fibrinolysis, and consider the need and safety of hemodynamic support and monitoring in the selected patients. For VTE, we should consider anticoagulant therapy. In these patients, the risks are like can be considered like we can consider that as a therapy, and they need that kind of therapy. So the risk is also high, but we take that risk because the conditions could go very like seriously, can be very seriously ill. And consider systematic fibrinolysis and catheter directed or surgical therapies in case not suitable for systematic fibrinolysis. And we should consider also the need and safety of hemodynamic support monitoring. The therapeutic consideration, practice, implication, and management of these patients. The wide spectrum of cardiac involvement in COVID-19 poses unique challenges in the term of clinical management and decision-making. In the context of COVID-19 pandemic, the treatment of patients with an existing or a risk factor for cardiovascular disease should be focused on active prevention or infection and complication, establishing an accurate and prompt diagnosis, and selection of the best available treatment without compromising the safety of the patients and the healthcare professionals. The allocation of medical and human resources, the diagnostic equipment, treatment facilities, and the nursing staff should be based on a prudent and informed risk versus benefit approach, because clinical resources may be scarce and access to the treatment can be particularly limited. But this cannot be overused. For example, like in some hospitals with like high load of COVID-19, if somebody like having a medical treatment, like very emergent medical situation like heart failure, they should consider like some resources for like the patients that are normal patients without COVID-19. So some hospitals, if somebody doesn't have COVID-19, they have like less resources for them. So they should like after some time, hospital should know how many staff and how much of their facilities should go through like COVID-19 ward, and other wards shouldn't be like neglected. Nursing management implications. The treatment and care of patients with COVID-19 who have cardiac involvement is a major challenge for all healthcare professionals, because a vast majority of these patients require critical care services, and they need more beds in the hospital. According to the recent report from the United Kingdom, 2/3 of patients with COVID-19 who requires critical care admission receive mechanical ventilation support. As a nursing staff, you should know that when some patient needs like mechanical ventilation support, so at least 2 or 3 nurses with like physicians should like be on site, and like it needs frequent visits. So it puts more pressure on the nursing staff and also like the healthcare professionals. And like the indications for endotracheal intubation. So we should be aware of that. If some patients don't need intubation, we don't do it, because as you know, it will like increase the mortality rate of the patients if it is not administered like properly. But if it is needed and it's not done, so the patient will die of the complication. So we should take a closer look at this indications for intubation and utilize the most experienced provider available. So because it's better to be done at the first try. So we don't want like unnecessary trying. Some hospitals like put like non-experienced like nurse or a health provider to manage this situation, and he or she will try several times. Then the risk of like making droplets and like contamination of other personnel goes higher. So with the first try, we want to like do the procedure. And video laryngoscopy, and I think video laryngoscopy is available in most of the hospitals now. So using N95 or other good and very sealed masks can be really helpful in the personnel in that kind of situation, because it causes a lot of like droplet generation in the air of that room. Oxygenation and tidal volume and respiratory rate should be considered like the indications for starting the endotracheal intubation in these patients. And reassess and titrate the ABG every 30 minutes after intubation should like be monitored, because nurse and staff want to like delay the procedure because they don't want to like revisit non-necessary. But we should know that every 30 minutes we need that titer, and it cannot be omitted from the sheets. Decrease FiO2 to targets to 92 to 96 saturation of oxygen, and titrates of PEEP based on the FiO2 and plateau pressure less than 30 should be our goal. Now I want to talk a little bit about nursing care in this epidemic. In this epidemic, there is a specific implication for nursing care, because nurses must deal with more than usual number of medically complicated patients and the multiple organ involvement. So they can be very busy in the hospital. With increased demand for beds, increasing volumes of cases, limited number of qualified critical care staff, and high sickness rates among healthcare professionals, delivery of high quality intensive nursing care will require practical and creative efforts and strategies and the solution in nurses. The nurses' main role in the management and care of patients with a cardiac condition and COVID-19 is to ensure safe and timely delivery of the care even when the ideal staffing ratio needs to be temporarily set aside. And because these patients usually are the sickest patient subset during this pandemic, meticulous individualized patient assessment and prompt institution of life-saving interventions are paramount and very important. And the risk of deterioration in these patients, cardiovascular disease patients, can lead to catastrophic outcomes. All patients with cardiac conditions and COVID-19 ideally should be placed in a monitored bed with facilities for continuous 5 or 12 lead ECG and blood pressure and pulse oximetry monitoring, because when I was talking about like the comorbidities and like heart failure, arrhythmias, all of these require like monitoring of these patients. Intravenous access should be always available. I think this is not a problem for most of the hospitals. The first thing that they do is like they start to like put a intravenous access in the patients, and because they should use like the bigger ones, and as nursing staff that you see that some of these patients are in need of multiple ports to simultaneously infuse a lot of medication onto coagulation therapies and like other kinds of medication. So use a bigger vein access, so you won't have a problem during the procedures. Patients who are hemodynamically unstable or require significant pharmacologic or mechanical support to maintain cardiovascular stability may benefit from a cardiac output monitoring device. And you can see pulmonary artery catheter, pulse contour cardiac output, lithium dilution cardiac output to guide the management and evaluate effectiveness of the interventions. Access to and availability of the facilities to provide more invasive cardio respiratory support, as like cardiac catheterization, pacing, intra-aortic balloon, and interpulsation, extracorporeal membrane oxygenation, and ventricular assist devices operating rooms should be included in the care planning, because these interventions may be required as the patient might go through cardiogenic shock or heart failure or even severe MI. This slide shows the standards of care under asymmetric pandemic conditions. So some hospitals and countries going through conventional like situation, as Taiwan before this like this current pandemic was in this stage, but I think now we are in the contingency phase. So the basic standards of care are maintained, and the alternations from a standard operating procedure to conserve scarce resources and limited rationing may be in the effort in the anticipating of the common crisis condition. But many countries that have been under crisis should be aware that substantial alteration to the delivery of care when demand outstrips supply of scarce medical resources, and they should be aware of like the patient autonomy subordinated. And I think like in the crisis, it's very important for the policy for policymakers to like make good decisions. Otherwise, the crisis will continue and continue. Most patients with COVID-19 with cardiac involvement are at higher than usual risk of deteriorating clinically. Therefore, drugs and equipment for resuscitation, including for stabilizing and artificial airways, mechanical ventilation, should be readily accessible to the bedside. These resources are like a little bit expensive for the hospital. So many countries with low resources cannot like provide this, especially for all the patients. But in a hospital setting, they should start to like ask for more equipment for these patients. Identifying the sickest patients in the unit should be a part of the daily handover to ensure safe allocation of skill mix and allow increased frequency of monitoring. The goals and plans of care should be reviewed regularly with the medical team and communicated to the rest of the staff to ensure the care is delivered within an agreed time frame and unexpected deviance and promptly addressed. Effective care planning with collaboration and active involvement of the multidisciplinary team is crucial because it's facilitate the continuity of care and the teamwork and accountability and better outcome for the patients. So I had talked a little bit about like the minimizing the COVID exposure during this pandemic, especially for the cardiovascular healthcare workers. So the procedures that is the interventional or electrophysiology and cardio surgery. So we should limit the staffing just for the urgent cases. So we cannot like put a lot of nurses on like some non-emergent cases, even if they don't have like anything else. So we shouldn't allocate a lot of staff. We should like keep some staff for like urgently admitted patients. Optimize medication or reschedule elective procedures. Don't call in the patients to the hospital if it's not necessary. Use the negative pressure, the catheterization lab. It cannot be like accessed through a lot of hospitals because of like lower resources. And consider the fibrinolysis in the case of PCI is not feasible. The cardiac critical care, we should wear like the appropriate like protective equipments. Use airborne PPE when it's really needed, and favor the external compression devices for CPR. For the echocardiography, we can reschedule elective procedures, of course, and use the bedside studies. Clean the machines and probes because it's like when they are using echo for the patients, they are using it for many patients because the demand for echo is like very high in the hospital. But we shouldn't like forget that it can cause like the transferring of the virus from one patient to the other patient. So we should have like some cleaning routine for echocardiography devices. Shorten the exam length if it's not necessary, and use the PPE as like always. For the outpatient cardiology, reschedule the outpatient one and use the telemedicine for all the outpatients should be necessary. And for the inpatient cardiology, limit in-person consultation and also telehealth in inpatient. And for the cardiology teaching services should be like going through online and like Zoom meetings or other Google or other things. Minimizing non-essential staff and avoid large group rounds and develop virtual rounds. Now is like very critical for nurses, students, and to learn something in the hospital because everything went online and nurses need to be educated. We shouldn't like exclude all the nursing teaching to the new nurses. So there are some risks, but there should be like balance with the benefits. So otherwise we will, because this pandemic might still continue to like a lot of years. So we should be aware of that fact and like educate good nurses that are like in these critical conditions would be very essential for the hospitals. So for the consideration of the patients and the healthcare workers and health systems during this COVID pandemic, if they have no prior cardiovascular disease and they have like a positive COVID-19, we should consider myocarditis, heart failure, cardiogenic shock, acute coronary syndrome, venous thromboembolism, and stress cardiomyopathy. And if they have prior cardiovascular disease and they have the positive COVID-19 we are talking about today, and we should heighten the awareness of cardiovascular sequelae and closer monitoring as worse prognosis. And cardiovascular medication interactions and toxicities should also be considered in these kind of patients.
Dr. Jafar?
Yes.
Sorry, because the times are almost up.
So how much time I have because we didn't start at
Actually, it's already up
Okay.
in 11. We can give you more like 5 minutes.
Okay,
Maybe you can
5
mention
minutes.
the
Okay, I will
point.
like sum it up.
Okay, thank you.
For the most important parts of how does the COVID-19 infection impact those with an underlying cardiovascular disease? To sum up, it can be this virus mainly targets the lungs and it affects the heart, making it work harder to carry oxygenated blood throughout the body, which increase the risk of heart attack and rapid onset heart failure. And COVID-19 infection could exacerbate symptoms of heart failure, especially heart failure. And viral illnesses are known to destabilize the plaques. That plaque will like migrate through the body and go and get stuck in the lungs or the heart. And patients who are older in age and have comorbidities are like the ones that weaken the immune system, are infected with the COVID, are at the highest risk. We should be aware of this fact. And previous coronavirus similar to COVID-19 have been linked to the inflammation to the heart muscle. This virus also has some studies that show that it can. So most of these considerations with the cardiovascular disease and the chronic conditions I had talked about. So I will go to the key issues relevant to the cardiovascular nursing. First thing is to reduce or minimize the transmission of the virus. Always wear the appropriate protective equipment. And for the patients with pre-existing cardiovascular disease have higher morbidity and mortality due to SARS-CoV-2. So we should be aware of this fact. And acute cardiovascular manifestations of core SARS-CoV-2 virus include myocarditis, heart failure, arrhythmias, and myocardial infarction. So we should consider all this as like the serious complications. Be aware of the delays in seeking care and avoiding health during this pandemic. So a lot of patients with the real need of the health care can be neglected. Medications that have been examined to treat this virus can also associated with the QT interval prolongation and arrhythmias. So we should like routinely check for these two conditions. Where possible, the transition to remotely provided care and adopt models of care and protocols in alignment with the current federal state government recommendations. Providing patients self-care management during the like relevant to COVID-19 and early conversations regarding advanced care planning, like life care is very important. And the practice of self-care and also telemedicine should be very important. The other slides are more useful to like the deciding which modality we can use to diagnose a patient. So I stop here after like summarizing all my lecture about like nursing care. Thank you.
Thank you.
So now is like the question and answer, or do we have that part?
We will have panel later, Dr. Java.
Okay.
We will have the second speaker first.
Okay. Thank you. I will mute my.
Okay. Thank you very much to Dr. Japa Alijargar, who has delivered an excellent topic today. And also moderator who has guided seminar in session 1 very well, Professor Wang. Thank you so much. Before we continue to the next session, we will have a short break for 10 minutes. Okay.
Can I try to share my?
Yeah, we will back at 10:10 EM, right? Well, ladies and gentlemen, we will start around 1 minute later.
Wipe,
Yes.
saya coba share screen.
Oke.
Bentar.
Prepare aja, Miss Julma.
Wipe ini share screen saya yang kelihatan cuma PPT kan? Saja.
Ya, kelihatan Bu PPT-nya.
PPT-nya saja ya.
Benar Bu.
Besar ya PPT-nya. Oke.
Big,
Oke, ini kelihatan besar, tetap besar ya di layar yang lain.
Yes.
Oke, thank you.
Oke, you will start ya. Oke. Miss Imamah, are you ready?
Yes, I'm here.
Yeah. Next, we move to the second session. We can invite our moderator, who is from University of Muhammadiyah Kalimantan Timur, Miss Imamah. Miss Imamah is a lecturer from UMKT, who is currently studying at NTU NHS as PhD students, right?
Yes.
We are very proud of you. Miss Imamah, time is yours.
Thank you, Mrs. Mukripa. And good morning, ladies and gentlemen. Today I will introduce our second speaker, Nurse Zulma Astuti MKep, or later we can call her Miss Zulma. She has graduated for Bachelor and Master of Nursing Science at Faculty of Medical Brawijaya University, Indonesia. And also she is expert on emergency nursing with basic and advanced life support as trainer, speaker, also instructor. Until now, she is also actively involved as member of Emergency and Disaster Nurse Organization in East Kalimantan or HIPGABI Kalimantan Timur. Before start the second session, we would like remind you to fill in the attendance link that has been shared by the committee. For Ms. Zulma Astuti, time is yours.
Thank you to Miss Imamah. I would like to share my PowerPoint first. Is my PowerPoint already see?
Yes, it's okay.
Okay. All right. Thank you again to Miss Imamah. Tajahau. Good morning, ladies and gentlemen. Dear all students from both of university. I'm very glad to be here with you today. We are connecting by Zoom because of pandemic, but wherever you are, I hope you all and your family are all safe and well. Today, we in Indonesia is still struggling with the second wave of the pandemic of COVID-19. And the current condition is still in the state of crisis, where the morbidity and mortality rates due to COVID-19 are still high. And this causes almost all hospitals in Indonesia face what we call disaster because the resources cannot meet with the number of the patient. And this is also because many of our healthcare workers, our doctors, our nurses are affected by COVID too. So there is a shortage of people to treat this patient. And almost every day, I hear news of the death of fellow nurse who is currently struggling to treat COVID patient, and they also died from COVID, and they are heroes to all of us. Excuse me, is my voice clear?
It's clear.
Okay.
It's okay.
All right. All right. In my presentation today, I will start by conveying the current state of COVID in Indonesia. The first wave of COVID-19 as a pandemic in Indonesia has occurred since March 2020. And nowadays, Indonesia is entering the second wave of COVID-19, where the morbidity and mortality rates from COVID-19 have doubled. The latest data regarding the number of cases COVID in Indonesia show the positive patient confirmed COVID-19 reached 3.7 million cases, and the patient recovered 3.1 million. And the data on patient who died due to COVID around 110,000 cases. Based on this data, based on this condition, the Indonesian government issue a community activities restriction enforcement regulation starting from June until August 23rd. And maybe if the number of cases of COVID continue to rise, then it will be extended longer. Here are the data from the government, from their official website. It informs us about the province in Indonesia, which have a higher rate of COVID. Jakarta is in the first ranks for COVID-19 cases, while our island, my island of East Borneo, is in the fourth place. It's not a good achievement, isn't it? The incidence of COVID in gender between men and women is not much difference, while the data based on the age of the patient, the most case occur at the age of 31 to 45 years. And for the data about sign and symptoms shown by patients who have COVID-19, such as cough, fever, cold, deep flu, sore throat, and others. And for the data of comorbid of the patient with COVID-19, we can see in the diagram 50% the patient who has COVID also has hypertension as a comorbidities, and 37% have a diabetic mellitus, and in the third rank is 16% heart disease. Okay, 40% of the patient with COVID who have hypertension as a comorbidity have recovered, while for patients who have heart disease as comorbidities, only 11% have recovered. In Indonesia, we also have been doing a vaccination program targeted to 100 million Indonesian, and from the data obtained, the implementation of the first dose of infection has only reached 24%, while the second dose has only reached 12%. Fortunately, all health workers for both doses have been 100% given. Okay, next to the move to the guidelines of diagnosis and management of cardiovascular disease during pandemic COVID-19. As I mentioned earlier, the most common comorbidities in patients suffering from COVID in Indonesia are hypertension, and also the third rank is cardiovascular disease. So it is very important for us to know the management, and also as a nurse to know the nursing care of for this cases. In Indonesia, there are several guidelines that can be used to provide service in cardiovascular case. One of which is from the Association of Indonesian Cardiovascular Specialists, who make guidelines for the diagnosis and management of cardiovascular disease in the COVID-19 pandemic. And this guideline provides instruction regarding the management of patients with cardiovascular disease during a pandemic. Cardiovascular disease and COVID-19, I think, have a reciprocal relationship. Patients with a history of cardiovascular disease are a population at a high rise for COVID-19 and have a fairly high mortality rate when exposed to COVID-19. Same as with explanation from Dr. Jafar before. On the other hand, severe COVID-19 infection is associated with acute myocardial injury and arrhythmias. Coronavirus causing acute cardiac injury and chronic damage to the cardiovascular system through several mechanisms, such as direct injury to a myocardium, systemic inflammations, imbalance between oxygen demand and intake, plaque rupture and thrombosis, electrolyte imbalance, and also side effects of various COVID-19 medical therapy. And I will not explain again about pathophysiology because it's already presented by Dr. Jafar in the first session. In Indonesia, documentation about a patient who has COVID-19 with cardiac injury complication is little, but I found some one case study about COVID with cardiac injury complication that has been published on Indonesian Journal of Cardiology. In this case report, show about the patient, 38 years old male, was admitted to hospital with symptoms of fever, cough, shortness of breath, and chest tightness 3 days before admission. 2 weeks prior to admission, he was diagnosed with hypertension. He had no history of previous contact with COVID positive patient or history of traveling abroad. And on arrival to the emergency department, the physical examination revealed that his vital sign was normal from cardiac auscultation, heart sound, or also normal. But for when they took 12-lead electrocardiogram recording, show diffuse inserted T waves on almost all leads. Blood tests show lipid level markers of myocyte necrosis, means that it's high sensitivity troponin T level, and also creatinine kinase MB level also rise. The patient was admitted in isolation ward with a diagnosis of suspected myocarditis and pneumonia. To determine whether a patient has heart disease or not is by looking from clinical presentation, electrocardiogram recording, and non-invasive imaging, and also a differential diagnosis. The problem is with clinical criteria for COVID-19. In acute cardiovascular condition is that the sign and symptom can be difficult to differentiate or even overlapping. Some clinical presentation that also appear in the both of disease such as shortness of breath and chest pain. And also, as a nurse, we must know how to examine chest pain, whether it's a cardiac origin or from another organ. Chest pain as a symptom of myocardial ischemic described as chest discomfort, heaviness, tightness, pressure, itching, burning, numbness, fullness, or squeezing. While in the patient with active COVID-19 infection, usually poorly localized chest pain and may be associated with breathlessness due to the underlying pneumonia. Another thing that is also a challenge for us when faced with a patient suffering from heart disease during a pandemic is when the heart problem is acute ST elevation myocardial infarction. As we know, the STEMI with unstable hemodynamic condition is an emergency case that requires immediate action. In COVID condition, pending the outcome of the screening COVID, we also should not wait too long to start action such as primary percutaneous coronary infarct intervention, because it will affect to their patient outcome. A case study showed the patient, 60 years old male, who came to emergency room with breathlessness and chest pain about 8 hours prior is diagnosis as acute inferior STEMI with acute lung edema and cardiogenic shock. COVID-19 screening was negative. Patient underwent PPCI, found to have a total occlusion of right coronary artery with thrombus and tight stenosis in left coronary artery. Successful PPCI to RCA was performed with type 1 myocardial infarction 3 flow result, and hemodynamic improved. 10 hours after PPCI, hemodynamic deteriorate and peripheral oxygen saturation dropped. His condition worsened quickly, and family agreed to do not resuscitation consent. From this case, the researchers suggestion that in this pandemic era, every emergency cardiovascular intervention with sign of respiratory problem should be performed as if a patient was a positive COVID-19 case. Okay, there is some guideline for STEMI and non-STEMI protocol for COVID-19. Patient with COVID-19 rapid screening criteria, positive code yellow with STEMI and stable vital sign within less than 12 hours of onset, receive fibrinolytic or thrombolytic in isolation rooms if there are no contraindication. When patient with contraindication, fibrinolytic or thrombolytic, risk evaluation for emergency PCI. If the patient has unstable vital sign and severe pneumonia, like fever plus of 1 frequency breath less more than 30 breaths per minute, severe respiratory syndrome, or oxygen saturation less than 90% in room air. The patient was given conservative therapy in an isolation room. Patient rapid screening criteria: COVID-19 positive yellow coat with STEMI and stable vital sign in the onset, more than 12 hours to evaluate the risk for PCI. Patient with COVID-19 rapid screening criteria for code yellow negative with STEMI are treated according to clinical practice guideline for STEMI. And for guideline for protocol for an STEMI, non-ST elevation myocardial infarction, patient with positive COVID-19 code yellow rapid screening criteria with STEMI are treated in isolation rooms, evaluate the need for PCI after recovering from COVID-19 pneumonia. Patient with COVID-19 rapid screening criteria code yellow negative result with STEMI are treated according to the clinical practice guideline for STEMI. Patient rapid screening criteria COVID-19 positive yellow coat with STEMI and unstable hemodynamic PCI performed in isolation catheterization room if available. Patient with a negative COVID-19 test will undergo further treatment at the intensive cardiovascular care unit. Patient with a positive COVID-19 test, further treatment is carried out in the isolation room and secondary prevention treatment after pneumonia repairs. There is some key points that also has been mentioned by Dr. Jafar to manage the patient with the cardiovascular disease during the pandemic. First, the management of patient with non-ST elevation ACS should be guided by risk stratification. The COVID-19 pandemic should not compromise timely repercussion of STEMI patient. Treatment of cardiogenic shock and of hospital cardiac arrest should follow current guidelines and current evidence. The same treatment strategy for acute heart failure can be applied in patient with and without COVID-19. Treatment of the hypertension should follow existing recommendation in the ESC, European Society of Hypertension guidelines. Monitoring a cardiac toxicity of antiviral drugs is recommended, and the more widespread use the telemedicine should be encouraged to minimize the risk of the COVID-19 transmission in both patient and healthcare provider. Moreover, the prevention is better step to minimize transmission of virus to the patient so that the morbidity and mortality because of COVID in patient with cardiovascular disease can reduce indirectly. Patients should be always protected from the exposure to COVID-19 infection, in particular because of the worst outcome for this patient group. Patients should be educated on how to protect themselves from virus contact. Patients admitted to the ward services should stay in the hospital for the shortest time possible, minimizing both professional and patient exposure to the virus. Any elective admittance for diagnostic or therapeutic purposes that may be postponed and should not take place during the virus outbreak. Okay, next to the nursing care guideline during COVID-19 in the COVID-19 pandemic. In Indonesia, there is no specific guideline for that case. I mean that in the cardiovascular disease during the pandemic. But the Indonesian National Nurses Association made a guideline for nursing care during the COVID-19 pandemic. The guideline contains there's several things that is very important to as a nurse we know about that. First, the use of personal protective equipment for nurses in handling COVID-19 patient. Emergency nursing care guide for the COVID-19 pandemic, guidelines for the prevention and management of COVID-19 patient in the area of maternity nursing and women's health, and guideline for nursing care in adult patient with pneumonia COVID-19, guideline for nursing care in critically ill patient with COVID-19, tracheal intubation in critically ill patient with suspected or confirmed COVID-19 pneumonia, guideline for nursing care for the elderly with COVID in nursing home, and the last is guideline for nursing care for the elderly with COVID in hospital. The important things that nurses do before providing services and nursing care during this pandemic is to use PPE properly, personal protective equipment. The aims are to protect health workers, especially nurses, from exposure to the coronavirus while treating the patient. The things that nurses know about PPE are the function of personal protective equipment, levels, type of personal protective equipment by that levels, the use of PPE in the triage room, emergency room, special COVID treatment room, or in isolation room, and non-COVID ward. How to turn on and off the personal protective equipment. Yeah, okay, because I have maybe my concern is in emergency nursing. I will start with the explanation in the emergency room that is one of the insurance for the patient to enter the hospital, as well as for the patient with suspected COVID-19 too. Health workers, including nurses who work in the triage area, perform screening and triage on patient. Implementation of triage, including separating the insurance of the patient with symptoms of acute respiratory tract infection, maintaining more than 1 meter of between triage officer and the patient and their families, giving a surgical mask to the patient if the patient has not used them, and the patient who are not suspected of having COVID continue with general triage, while for patient with suspected or confirmed COVID-19 are placed in isolation room. And in emergency room, we can use early warning system that has modified for the situation of the pandemic, to early detection of worsening condition that may occur in the patient. Sorry. Further is to examine the main complaint that caused the patient to seek help. Next, we do the primary survey to see if there are any life-threatening conditions such as obstruction in airway, difficult to breathe, circulation disturbance, and also to see the patient consciousness status. And we also assessment for the vital sign of patient, and if there are no condition can like threaten the patient condition, we move into the secondary survey. In the secondary survey, we do a physical examination and anamnesis the patient for their allergic medication, past medical history, last meal, and event. And the last is assess for the patient anxiety and distress. And conduct or recording the ECG, take the blood for the laboratory, and do the X-ray examination. One of the complications from both cardiovascular disease and COVID-19 infection is cardiac arrest. As a nurse, we must know how to give a resuscitation for that patient. The proper management to help patients who get cardiac arrest will increase the survival rate of the patient, and also minimizing the transmission of COVID virus from a patient to a healthcare provider. General principle of resuscitation in suspected COVID-19 patient is to reduce the exposure of health worker to COVID-19. The second is prioritize oxygenation and ventilation strategies with lower risk of aerosolization by installing HEPA filters on ventilation device, and consider the appropriate of initiating and continuing resuscitation. If the cardiac arrest happened in out of hospital and during the pandemic, the American Heart Association has made an algorithm for that to management of the patient who get a cardiovascular cardiac arrest in out of hospital. There is some step or the lay person can follow. First, check for the response patient. If there is patient in the out hospital suddenly unconsciousness, we check for the response, and if there is no response, immediately call for help and ask to bring an AED or automatic external defibrillator. Because if the underlying cause of the cardiac arrest is arrhythmias or the lethal arrhythmias such as ventricular fibrillation, the AED can make it survival rate become raised. The second step is cover the rescuer mouth and nose with a mask or cloth, and also cover the victim's mouth and nose with a mask or cloth. And the third step, we do hands-only CPR to the patient. So we don't use ventilation to not give the ventilation to that patient. And only hands-only CPR with a speed of 100 until 120 times per minute. And if the AED has arrived, immediately use the AED. If presence of spontaneous recirculation is not achieved after appropriate resuscitation efforts in the field, consider not transferring to the hospital to reduce the risk of additional exposure to pre-hospital and in-hospital care providers. And for the cardiac arrest who happen in the in-hospital before cardiac arrest occurred, carefully monitor and monitoring the sign and symptom of the patient clinical deterioration during cardiac arrest and resuscitation. Perform the following steps, such as close the door during resuscitation to prevent airborne contamination of adjacent rooms. Immediately intubate the patient during cardiac arrest and then put on a mechanical ventilator with a HEPA filter to maintain closed circuit and reduce aerosolization. If circulating spontaneously achieved, adjust the ventilator setting according to the patient's clinical condition. And immediately after resuscitation, must consult the local infection control team regarding to transfer of the patient after resuscitation. Okay, next to the nursing care process. As we know, the nursing process consists of 5 sequential and related stages. This includes assessment, diagnosis, planning, implementation, and also evaluation. Assessment, we can do the primary triage, such as symptom of acute respiratory distress, travel history, contact history with confirmed or possible COVID case. And we also do the primary survey, assessment of vital signs, secondary survey, and psychosocial assessment include anxiety and distress. For nursing diagnosis, for the patient who came to an emergency room, are ineffective airway clearance related to the airway hypersecretion impaired, gas action related to metabolic disorder, respiratory muscle weakness, risk of shock related to decreased ventricular function, impaired spontaneous circulation related to decreased ventricular function, and the last is anxiety related to situational crisis and threat to death. For nursing intervention, we have for nursing intervention. First, we must observation and monitoring the condition of the patient, do some therapeutic, and then give patient and their family education, and also collaboration with the other health workers. Nursing plan intervention for the patient with COVID-19 is airway management. Monitor breathing pattern, sound monitor the amount, nature, and cause sputum, maintain a pattern away, position semi-polar, recommend adequate fluid intake, teach effective cough technique and cough etiquette, collaborative administration of bronchodilators, expectorant, and mucolytic. And the second is respiration monitoring. Nurse must monitor the frequency, rhythm, depth, and effort of breathing, monitor breathing patterns, monitor cough ability actively, monitor for sputum production, monitor for airway obstruction, monitor for oxygen saturation, monitor blood gas analysis values, oxygen therapy, monitor oxygen flow rate periodically, monitor the effectiveness of oxygen therapy, maintain a patent airways collaboration for oxygen dosing. To prevent the shock, monitor level of consciousness, and then cardiopulmonary status monitor, monitor oxygenation status, fluid status monitor, give oxygen to maintain saturation above 94%, insert IV line if needed, insert a urinary catheter to assess urine output if necessary to, explain the cause or risk of shock, sign and symptom to the patient or their family, recommend reporting if you find early signs, symptoms of shock, and recommend oral fluid intake as needed. Collaborative administration of intravenous fluid is if necessary. Collaborative transfusion if also if necessary. And for the last is in anxiety reduction, create the therapeutic atmosphere for to foster trust, calm, and comfort. Listen to the patient complaint with full attention and active listening. Discuss realistic planning of upcoming events. Explain the procedure to be carried out, including the sensation that may be experienced. Teach for non-pharmacological relaxation techniques such as deep breathing and guide imagery. For nursing evaluation, our target is increased airway clearance, increased gas exchange, increased spontaneous ventilation, shock level decrease, increased spontaneous circulation, and decreased anxiety levels. In nursing implementation, implement all the intervention that has been determined according to the needs of the patient, and if necessary, conduct the reassessment if the intervention doesn't have an impact on improving the patient condition. And the last, nursing documentation, record the data and the time of the intervention by the nurse. Record all independent and collaborative intervention will be done and has been done. Record all changes in the patient's psychological response to the intervention. Record the patient's psychological response to his condition and intervention that have been given. Record the evaluation of intervention that have been given. And for last statement from me, the evaluation and documentation about management and nursing care for COVID-19 patients with or without comorbidities in Indonesia has not been widely published yet, and its investigation further. Lastly, I want to read a hadith from Prophet Muhammad SAW that the best human being is someone who does the best thing for others, and our healthcare provider are the one of the best human being because they care others with sincerity. Thank you for kind attention. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
wabarakatuh. Thank you for Ms. Zulma Astuti for a great presentation that's focused on the emergency care for cardiac arrest. And now the time I will return back to the Master of Ceremony, Mrs. Mukripa.
Thank you.
Okay.
Thank you very much to Ms. Zulma Astuti, who has delivered an excellent topic today, and also the moderator, Ms. Imama, has guided the seminar in session 2 very well. Next, we move to discussion session. And for our participant who has any question to both of our speaker, Dr. Java and Ms. Zulma Astuti, you can raise hand and also write your question in chat column with format tanya or ask, and then full name underscore institution of origin, and also you can write your question in the column in chat column. Okay. There are many questions, right? Okay. Dr. Japa and Professor Wang are ready here?
Yes, I'm here.
Okay, Dr. Japa. Okay, the first question from Siti Munawara. Siti Munawara. Okay. You can speak. Time is yours. The first person.
In raise hand.
Raise hand, Dinda nurse. Okay, Dinda. Dinda. Okay, Dinda.
Yes.
Is you already write in the chat column your question?
No, can I speak in here?
Yes, you can.
Yeah, okay.
I think you can ask now.
Is my voice clearly?
Yes, yes.
Okay. First, I want to introduce myself. My name is Dinda, and I'm student of Universitas Muhammadiyah Kalimantan Timur. Thank you for the opportunity that given to me, and also thank you for Dr. Jafat and Ms. Zoma for share experience and knowledge for us. I enjoyed. So about my question is, during the pandemic, a lot of people with comorbidity afraid going to hospital for medical checkup because they're afraid that getting infected. Even they're afraid getting to test because they're afraid to know that if they're positive COVID-19. And if the telemedic isn't available, what we can do? Is there any special care that we can do to prevent things that we don't want to? Thank you. The question for Dr. Jafat, by the way.
Okay, thank you very much. Actually, home visits are another like alternative option that people have, but I think if a country is like not in very good insurance system, so it cannot be reimbursed. So those patients are in danger of like losing some money because of that, especially if their conditions are chronic. They might need like good resources to do that. So hospitals should think about like chronic patients that need care during this pandemic and provide them like services. Maybe they will provide some clinics out of the hospital, out of the main hospital, and they provide like services special for chronic heart failure or like chronic kidney disease that need dialysis every other week or every week. And they will like separate the infectious department to like higher floors, or like separate the patients with like special care to the special rooms with good services. But other than that, it needs good resources to like make a special care for these kind of patients.
Okay. Dinda, is clear?
Yes, Miss.
Okay.
Thank you.
Okay, the second.
I just have some supplement information for Dinda, patients nowadays are very afraid of going to hospitals of the potential infection of COVID-19. However, hospitals in Taiwan now, we usually have phone calls, a phone outpatient department. They can just call the outpatient department if they have any concerns or issues. We also have videoing outpatient department for patients who can book first. And so they can use Zoom to talk to the doctors instead of visiting hospitals. So all these, what we are doing today like that can also offer to the patient, especially the chronically ill patient, when they have heart disease or cancer or other renal disease, chronic renal disease. All these patients need to have that access so that they can be cared for immediately if they have symptoms. So phone call is available for hospitals in Taiwan. And I think that is very good access for elderly. Thank you for your questions.
Thank you. So in Taiwan, they can do consultation with their specialist doctor?
We have, yes, all our specialties has assigned a doctor who doing videoing outpatient department. So we have all the specialty and the video outpatient kind of consultation has already arranged for all the specialties. So if they have that, for example, if they have cardiovascular disease and they want to talk to a specialty using video consultation, they have to book first.
That's great. Thank you.
No worry. Thank you.
Thank you, Prof. Wang. And we move the second raised hand from I can see Dean of Faculty of Nursing UMKT. Yes.
Thank you.
Dr. Haja Nunung, time is yours.
Thank you very much, Miss MC. I have a question to Dr. Jafat. Hi, Dr. Jafat. I have experience got COVID-19 a month ago and done self-quarantine at my home. Nowadays, I'm getting better and check swab PCR result is negative. But I still have a shortness breath or difficult to breathe if I doing something like going upstairs or taking a bath. And I've got a little cough too. Would you mind to give me some explanation about why I still got that symptom? Thank you, Dr. Jafat.
Thank you for the question. And nowadays, a lot of healthcare professionals like you also like experiencing like this infection because it is like now very widely spread. I'm very sorry about like hearing that you were infected with this, and very happy that you already got very much better. And I can say that cough as a symptom of viral infection can last for a month or two, even after like getting resolved, like after getting much better. But the other thing that you should be aware of is that the long syndrome. It's like the COVID has another kind of manifestation that can be like in the patient for a longer time, longer than other viral infection. And even with a negative test, it's not ruled out that you are completely like virus free. But it has low probability that mostly it has been resolved and you should be sure. But about the long involvement of COVID, it can take up to a year to like fully recover from the complication, and in some patients is like it's even like take longer time. So maybe giving yourself like more time will resolve these kind of sequels that has been in your cardiovascular system.
Okay, I see. Thank you, Dr. Jafar.
Welcome.
Okay, thank you, Dr. Japa. Well, we will move some question from chat column from Pita to both of speaker, Dr. Japat and Ms. Julma. How far is the effect of vaccination on transmission of COVID-19? As we know, the people who have been vaccinated are still infected with COVID-19. Okay, thank you. The first is Dr. Java, and the second, Ms. Julma.
Well, about the vaccination, I didn't present my slides about the vaccination. So if I want to briefly just mention, there are 3 types of vaccine available in the US market. So it's Pfizer, it's Moderna, and Johnson & Johnson. And mostly the first 2 are like most effective ones. And recently there are some reports to say that even with vaccination there's going to be like infection, but it has been reassured by the vaccination company with a lot of like large studies that people with vaccination have lower mortality rate. And so it's like the vaccination is not without any effects. So, and these are just reports that some people with like full vaccination got the flu. But still thinking about like the health outcome and like the community like results of vaccination is still very encouraging, and people with full vaccinations are mostly having a very good immunity against the infection.
Okay, thank you, Dr. Japa. And how about Ms. Julma?
Yes, thank you for the question. Actually, I don't get any vaccine yet, but I believe that vaccine will, way to teach our immune system how they get face the any virus, and then if the vaccination has been taken to the patient is still infected, maybe the sign and symptom much lebih apa itu namanya, not nggak terlalu berat apa?
So heavy.
Not heavy with people who not get in vaccine yet. So I believe the vaccine will
kalau nggak ngerti jangan dikerjain.
And can save a lot of people with the vaccine. Even it's more need investigating for the effectiveness of the vaccine. That's all.
Okay, thank you, Ms. Julma. We move to a person who asked question through raise hand. Please time is your to Dia Sud.
Hello, can you hear me?
Yes.
Okay, good morning, Dr. Javad. I would like to ask a question for you. First of all, I would like to say thank you for the opportunity that given to me. It's such an honor. For both of the speaker, for Dr. Javad and also Ms. Julma, it's such a enjoy material. So the question I'm really curious about and I want to ask is about the vaccine. As a health worker, I mean, in the future, especially as a nurse, we're not only focusing on the caring and curing, right? We're also talking about the preventive action. And in this situation, in COVID-19 era, the one of prevention action is vaccinated, right? And before we got vaccinated, we have to do the vital sign, like for the blood pressure, the temperature, and etc. What if the coronavirus, the person that have the coronavirus disease want to have the vaccine itself, and they have like such as hypertension, are they can get the vaccine, and also if they can, why, what make them they cannot get the vaccine, and if they can get the vaccine, is there any value for the tolerance for blood pressure itself? I mean, I hope you understand my question.
Okay. Thank you, Jesut.
Okay, thank you for this question. It is like for different vaccines have like different protocols. Mostly they are like recommended to all of the patients unless there's like a very serious condition. For example, DIC, the patient's in shock, or it's like having like a very high stage of cancer, or like other conditions like coagulopathy conditions. They have been like more prone to like bleeding. Unless one of these conditions available, the vaccination is recommended. All of these vaccines like Pfizer, AZ, Moderna, or Sputnik, the Chinese vaccine, or other types, all of them have announced that it is very safe in a lot of like age groups, and also most chronic conditions. So about like the specific conditions of every patient, the physician should decide the risk versus benefits of that vaccination. And even with the people with infection, they are administering the vaccine even to them, because they will boost their immune system for this. But there are also other reports that have been like from other countries, or about like the vaccines that have been given to some of them exacerbated the condition of the COVID-19 patients. So it's still under study, and there is no definite answer for like all of the vaccines. But every physician in every setting will recommend the good suggestion to the special patient with some conditions.
Okay. Okay, thank you, Dr. Jafar. Okay, is it possible to the last question, because time is over to this question. Okay, the last person to what is it? Duina Octavia. Okay, time is yours.
Maybe Dr. Java want to choose one more questions to answer, because there's a lot of comments and questions, popular. And thank you very much for all the audience actually, leaving a lot of questions, and hopefully we can actually write to each other, or maybe some other time. But I think the time is up. And so, Dr. Java, I want to choose one more question.
Okay.
You can choose through chat column, Dr. Java. Because
I have been like scanning these. There are some good questions here, and also Jason asked me a question about the painkillers that I find it like very useful if we have some information about painkillers. So at first, there was some rumors that painkillers, especially ibuprofen, will cause like some protection against this virus. But later there were like some studies that's showing that it will like upregulate the ACE2 receptors. So it might be dangerous. But after that, WHO like tried to resolve this with a lot of studies, and showed that there is no definite like risk of taking NSAIDs during this disease. But as my own experience, if people are in pain because people of COVID-19, and now is like people that get vaccinated have some experience of pain, especially with some of these vaccines. So the best painkiller is simple acetaminophen or paracetamol that is like shown to be safer than NSAIDs, because NSAIDs has been like it goes through some cytokines and it will induce some upregulation or downregulation in some receptors. So it is safer to take simple painkillers, non-NSAIDs. NSAIDs are like a little bit more risky to take, as my own experience.
Okay. Okay, thank you, Dr. Jafar.
Can I ask some question?
Okay. Okay. Okay, the last
Okay.
right.
Thank you, Dr. Jafar. Question from me is when people with hypertension comorbidities and also has COVID, why the blood pressure down into the normal level or under the level? So what can do to this patient? Thank you.
You're asking me, right? You mean
Yes.
it's like
If-
hypotension.
Yes.
You mean hypotension.
Yes.
So nowadays there's a shortage. Nowadays in Iran there's a shortage of like serum, the IV therapy serum for the patients. It shows that there is a big demand for IV therapy. And if you consider this one, this COVID-19 as a viral infection, so IV therapy for viral infection is very seriously needed. One of the reasons is lower blood pressure that has been induced after like the viral infection or DIC after that. So simple saline and IV therapy should be always available for the patients. And it is the most important thing because antivirals, antibiotics, all of these are supportive medicine. But the thing that all of these will kill in days, but hypovolemic syndrome will kill in minutes. So we should be aware of that thing. It is very important.
Okay.
Thank you so much for your answer.
Okay. Yes. Thank you, Dr. Java. Thank you, Miss Juloma. It was very insightful presentation, and we are so sorry to all participants. Not all question we will answer today. All of the participants can get a clear understanding about the topic presented today. Well, ladies and gentlemen, we are coming to the end of our event today. On behalf of committee, I hope you have found this program is informative and useful. From the depths of my heart, do apologies if we have done any mistakes in presenting this event, and we hope can meet you in another opportunity. Thank you for your attention and have a nice day. Wassalamualaikum warahmatullahi wabarakatuh. Sini.
Waalaikumsalam warahmatullahi
wabarakatuh.
Bu Ipeh disampaikan ketemu jam 1, Bu Ipeh.
For the next break session, and we will continue our meeting in 1 p.m. right?
Yes.
To session about our joint reset. Okay, thank you for your attention.
Health to everybody.
Yeah, see you.
Remember to wear your mask and wash your hands and wear your goggles.
Thank you, Miss Catherine Wang.
Any vaccination is good.
Thank you. Thank you.
Bye.
Thank you.
Thank you.
Terima kasih.
Thank you,
Terima kasih.
Miss.
Sama-sama. Yeah.
Sama-sama.
Thank you.
Oke, silakan yang mau live.
Mr. Ade.
Ya, Mbak.
Company profile.
Mbak. Oh ya.
Belanda.
Wait.
Baru Raji Rasihan kenapa?
Kepencet, Bu.
Oke.
Izin keluar, Bu, ya. Assalamualaikum.
Allah ya barakati ya, silakan.
Izin live, Bu. Assalamualaikum.
Ya,
Terima kasih. Salam, sukses ya.
Ya,
Terima
silakan.
kasih, Bu.
Makasih,
Sehat ya,
Bu.
Bu Siti. Ya, terima kasih.
Harus diarahkan seperti apa?
The sun will be guiding you. Run, boy, run. They're trying to stop you. Run, boy, run. This race is a problem. Run, boy, run. Life is scary. Hey, hey. And you don't have
Jadi anak-anak yang
Oke. 맞네.
개그맨입니다. 사이신 저는 화가입니다. 전 경찰이요. 넌 여기서 경찰을 할게. 네? 둘중 한번 거짓말. 저 11이. 거기서 진실이어서 제가 계산한 거와 정말 비슷해요 지금. 그 형은 대학에 준비하고 일단 진실을 먼저 얘기했을 거. 준비형 성격상 일단 먼저 얘기는 했을 것 같아. 일단 진실로 생각하고 내가 준비형 처음에 시작할 때 눈빛이 또 달라진 것 같긴 해.
Selamat datang di kota tepian Samarinda, pusat pemerintahan ibu kota Provinsi Kalimantan Timur yang dibelah salah satu sungai terpanjang di Indonesia. Kebutuhan sumber daya manusia profesional sangat diperlukan demi mendukung pertumbuhan kota. Universitas Muhammadiyah Kalimantan Timur, salah satu dari ratusan perguruan tinggi yang didirikan oleh Persyarikatan Muhammadiyah. Universitas Muhammadiyah Kalimantan Timur merupakan manifestasi dakwah Muhammadiyah di bidang pendidikan dalam upaya untuk ikut mencerdaskan kehidupan bangsa yang didasari oleh nilai-nilai moral dan Islami, khususnya Kalimantan Timur. Universitas Muhammadiyah Kalimantan Timur bukanlah penyelenggara pendidikan pendatang baru di Kalimantan Timur. Diresmikan pada tanggal 28 Agustus 2017, kampus ini merupakan penggabungan dari dua sekolah tinggi di Samarinda. Sekolah Tinggi Ilmu Ekonomi Muhammadiyah Samarinda dengan Sekolah Tinggi Ilmu Kesehatan Muhammadiyah Samarinda yang berpengalaman dalam mengembangkan dimensi-dimensi manusia secara seimbang, baik moral spiritual, intelektual, fisik, dan keterampilan bekerja dalam kurun waktu 30 tahun. Dengan mengembangkan dimensi kemanusiaan yang lengkap tersebut, Universitas Muhammadiyah Kalimantan Timur diharapkan menjadi pusat pendidikan alternatif dan unggul agar mampu membentuk manusia Indonesia yang sesuai dengan kebutuhan bangsa. Universitas Muhammadiyah Kalimantan Timur mempunyai 2 kampus induk dengan luas area sekitar 15 hektar. Kampus 1 terletak di Jalan Insinyur Juanda nomor 15. Kampus 2 terletak di Jalan Pelita, Komplek Pesona Mahakam. Menawarkan lingkungan yang nyaman bagi kegiatan belajar, mengajar, dan penelitian. Universitas Muhammadiyah Kalimantan Timur memberikan berbagai fasilitas seperti ruang kuliah representatif, perpustakaan terpadu, hotspot internet gratis, musola, kantin kampus, serta laboratorium pembelajaran yang diantaranya adalah laboratorium keperawatan, laboratorium kesehatan lingkungan, laboratorium mikrobiologi, laboratorium komputer dan internet, laboratorium bahasa, laboratorium teknik mesin dan teknik sipil. Didukung lebih dari 120 dosen dan 39 karyawan berpengalaman dengan kualifikasi yang baik. Terdapat 8 pilihan fakultas dan 16 program studi di Universitas Muhammadiyah Kalimantan Timur. Fakultas Teknik dengan program studi Strata 1 Teknik Informatika, Strata 1 Teknik Mesin, Strata 1 Teknik Sipil, Fakultas Keguruan dan Ilmu Pendidikan dengan program studi Strata 1 Pendidikan Olahraga, Strata 1 Pendidikan Bahasa Inggris, Fakultas Ilmu Keperawatan dengan program studi Diploma 3 Keperawatan, Strata 1 Keperawatan, Program Profesi Nurse, Fakultas Kesehatan Masyarakat dengan program studi Strata 1 Kesehatan Masyarakat, Strata 1 Kesehatan Lingkungan, Diploma 3 Kesehatan Lingkungan, Fakultas Farmasi dengan program studi Strata 1 Farmasi, Fakultas Psikologi dengan program studi Strata 1 Psikologi, Fakultas Hukum dengan program studi Strata 1 Sarjana Hukum, Fakultas Ekonomi Bisnis dan Politik dengan program studi Strata 1 Manajemen, Strata 1 Hubungan Internasional. Menjadi bagian dari institusi pendidikan di era globalisasi, Universitas Muhammadiyah Kalimantan Timur bekerja sama dengan institusi perguruan tinggi, baik dalam negeri maupun luar negeri, untuk memperluas pengetahuan dan mobilitas. Universitas Muhammadiyah Kalimantan Timur membuka seluas-luasnya kesempatan bagi mahasiswa berprestasi baik dalam maupun luar negeri, dengan banyak skema beasiswa yang ditawarkan, termasuk kepada penghafal Al-Quran. Mahasiswa Universitas Muhammadiyah Kalimantan Timur berkesempatan untuk berbagi pengetahuan dan berkreasi yang berdampak positif terhadap lingkungannya. Kegiatan mahasiswa dirancang untuk menambah pengalaman dalam menghadapi persaingan kerja dan mempersiapkan mereka menjadi pemimpin yang berkarakter, berwawasan, dan berkemajuan. Universitas Muhammadiyah Kalimantan Timur bertujuan untuk menghasilkan lulusan sebagai kader persyarakatan, menghasilkan umat yang piawai memanfaatkan teknologi informasi demi pembangunan bangsa dan memperhatikan kelestarian lingkungan, serta menghasilkan produk iptek yang ramah lingkungan. Semua hal tersebut kami lakukan demi mewujudkan komitmen kami pada tahun 2030. Universitas Muhammadiyah Kalimantan Timur menjadi universitas Islami berbasis teknologi informasi yang unggul di berbagai bidang dan berkontribusi terhadap masalah sosial maupun lingkungan.
Di mana Pak dari bentuk anak itu tanah itu di utang
令人心甘的60届所谓的智慧，一个字，对不起起来。但是现在来，我绝对并不能留心。它一个人心的系统在不不过人心才在一起。其實講實雖然，只唔過真係是實際上講係唔對，你先買嘅唔得，你哋講真。有冇楊先生之前啲特點特別有見？對上啲系統話，當然唔係主要。我拿的一定的多數第六句有印象。小飞叶。去看看上次的引起小剧啊，以前我做 CPR 时阵应该开光卡。应该做我諗做啊，跟我自己數定七十萬。你家不做在微邊啊？
Is my voice okay, Jason?
Okay. So everyone can hear me?
My voice okay?
Yes, my voice is okay. Okay. So now we would like to start the section 2, the afternoon section. I'm really happy to have the chance to have this section. I think this section will focus on the research cooperation and discussion. And so first, I would like to have an introduction for the first speaker of this afternoon section, Professor Wang. So now I will have a short introduction. Professor Wang, Professor Kaiwei Catherine Wang is an academic staff working in National Taipei University of Nursing and Health Sciences, teaching pediatric and family nursing both in undergraduate and postgraduate programs. And she is currently responsible for international nursing program in our university. And her research focuses on family of children with critical illness and health care of children with special needs, and have published several research papers in well-known international journals. So really happy to have Professor Wang in this research forum. So I will now give the time to Professor Wang. Thank you.
Thank you, Jason. Thank you. Thank you again for everybody. I'm going to just share my screen now. Can you see my screen well? Okay, that's great. Good afternoon, everybody. As Jason has mentioned, it's a wonderful time that we can actually see each other and meet each other in this virtual conference. And it's nice to meet some of the students and faculty. And also Dinunun, it's love to see you again on the the virtual conference, and hope you well. And
Thank you.
it's not comfortable with the COVID infection. So a lot of rest and drinking water is essential. Okay.
Okay.
Yeah, that's great. First of all, I would like to introduce myself first. So as Jason was talking about, that I actually from a pediatric and family nursing background, and I know today we are going to talk about cardiac care. So in the first part of my presentation, not just introducing myself, but also I will try to talk a little bit about cardiovascular care or cardiac surgery care, postoperative care for cardiac for children, infants, and children with cardiac disease. Okay, now our children are beautiful and they are vulnerable. Okay, so what can we do as a nurse to help them? Especially in the COVID-19 pandemics, our children are having no vaccination at the moment available for them, and they are they are confronting the threats of Delta variants as well at the moment for the global wide. So we are very concerned and worried about our children. And so I think it needs a lot of efforts and care from adults to be, first vaccinated and also protect our children from this COVID-19 infection. Okay. Just a little bit about myself. I'm actually from a pediatric intensive care working experiences before I actually do my research and PhD. At the time, I was looking after critically ill children and with different kind of disease, can be respiratory disease, cardiac disease as well. My research, because our in the afternoon session is about a little bit about more on individual research, and we can help each other in after Lucas' presentation a little bit more interactive ways to have some ideas and questions about your own research as well. So I hope to make this research forum a little bit more interesting and interactive. So first of all, I would like to let you friends from UMKT knows that I both do qualitative and also quantitative research in the area of pediatric nursing care for caregivers and children, and also some related to critical care in children and adults as well. I also like to do some, have a bit of play with systematic reviews, especially from JBI and also from Cochrane. And so I have some experiences to do with myself and with my research students using meta-synthesis as well. So this is a little bit background of myself. Okay, my achievements and disseminations usually try to write published papers is important, especially in SSCI and SSCI papers. So as being the first author or correspondence author from the last few years, I have tried to write paper to Journal of Advanced Nursing and Nursing in Critical Care, Journal of Pediatric Nursing and Clinical Nursing Research. And they are all pretty good in their ranking as well. So in the research purpose, or like what we are talking about in this afternoon, a lot of friends from UMKT has already posed some questions about, factors related to emergency care for patients or family who are self-quarantine at home, which is, I think, a great topic to talk about, and also think about the titles or directions you want to write for your papers in terms of your research. So my understanding that you are also interested in about telehealth, telenursing, telemedicine. So in my previous years, I have some funding to actually establish online support forum for the families of home ventilation. So I can share with you in the end about my online support forum, how I actually developed that based on my research papers. Okay, and also that I think having be able to participate in international conferences is important, just like we are today, to meet each other, to exchange ideas. So like last year, this year, our conference is different. Our ICN conference that I attended, which is being held in Taiwan, personally. And this year, just now, I just finished my virtual conference oral speaking in Sikimatau. So, which is these two nursing conferences are big, and it would be nice if you can actually have some chance to participate them. Okay. Now, as I said, my research application focusing on pediatric care. So it's about family care in children in the context of medicalization. So for example, children with oxygen dependent. From my qualitative study, I always do with children with tracheostomy staying at home. So they are breathing difficulty and they also need ventilators at home. And then I started to develop some of the questionnaire research to actually much more detail to analyze the needs and the problems of the issues confronted by the families looking after children with home ventilations. And then so my second research application would then look at the family function. From my previous qualitative studies and also current, more current survey study, we have found that some of the family functions are not just about learning about the skills, nursing skills or technical skills required to look after these children at home, to actually get them better in terms of growth and development. It relies a lot of highly technical parenting skills to look after these children at home. So integration of technology is important nowadays, especially in this phase of COVID-19. Everybody has to be self-quarantine. Even you are a healthy person, you also have to be self-quarantine to protect yourself and protect others. So using technology, telemedicine, virtual consultation is one of very important things. But then you need to look at what is the needs of the patient when they're at home. What do they actually most concerned? And these are the key questions you have to ask when you're actually doing the research or help these patients self-quarantine at home. So what are you going to teach them? You can't teach them too much that they can't digest. They are already feeling sick. They already, are feeling very tired. And so in the online support, you need to look at how to step by step to help your patients. I think this is what I actually have learned from the last 10 years. And so I have developed video, short videos to teach parents to care for their children in different ways, in different things, like how to sanitizing tracheostomy tube, or how to do the suction when you're at home. And so short videos, I think I have been doing that. I also have doing a lot about parenting communications. And so not just about the parent-child relationship as well, also how to help the healthcare professional to communicate with the families and parents who are actually very anxious at home, looking after their children who are sick. Okay, so a lot of clinical setting can also be considered when you are framing your research questions. You can look at how clinicians can really help and providing help to the families and to your clients and patients. So I think communication is one of very important things, to different types of patients. Okay, so two aspects of my sharing, and do remind me if I talk too long, because I'm afraid that I probably don't have much time, but I'm going to rush out a little bit with my presentation. A lot of content is in here I have prepared for you. So 2 aspects of my sharing today are intensive care with infants and children, especially postoperative surgical care in infants with cardiac disease. So we look at the postoperative transferring pulmonary hypertensive crisis, ventilation, early extubation, infections, prophylaxis, sedation, pain management, nutrition, postoperative glycemic control, and improving communication with family in the context of PICU or NICU. And then I will a little bit sharing about my telehealth that I do with my special children and family using the online support forum. So working in pediatric cardiac intensive care unit demands professional nursing knowledge and practical skills. We must be knowledgeable about the human responses of these children. Many of their responses are physiological, and yet there are other psychological, behavioral, and family responses that are also very important for pediatric nurses to understand, diagnose, and treat. Postoperatively, these infants are at risk of hemodynamic instability, persistent hypoxemia, arrhythmia, and multi-organ dysfunction and seizures. We need to watch out for the circulation, including palpation of peripheral pulses, including femoral and brachial, visual check of the pressure parameters on the monitor, for example, arterial blood pressure, CVP or LA pressure, and check for the capillary refilling time. And we also have to assess the respiration status. Is the chest moving? How are the chest movements, symmetrical lung expansion, adequate expansion, or how the oxygen saturation looks like. Similarly, we also have to watch out for the bleeding. Are the strands connected to the suction? How much is the bag and how quick is feeling? Are the secretions dark red, meaning venous blood bleeding, or bright red, meaning arterial blood bleeding, yellowish or clear, warm or cold? When we assess the neurological status, you have to look at the patient is sedated. What is the status of the pupils? Are there spontaneous movement? Is the patient breathing against the ventilator? Assessment of body temperatures, catheters, lines, and cables inserted are all very vital. There are a variety of factors that can result in myocardial dysfunction and subsequent low cardiac output postoperatively. Typically, they include an inflammatory reaction to the cardiopulmonary bypass, and myocardial ischemia, and inadequate myocardial infarction as a result of intraoperative clamping of the aorta, intraoperative hypothermia, a perfusion of edema, or if surgical procedure was performed using a ventriculotomy. So, coronary, we also have to look at inadequate cardioplegia or mechanical alteration or infection. So unstable signs and symptoms are many, including tachycardia or the urea, delayed capillary filling time, hypotension and decreased pulse pressure, reduced mixed venous saturation, metabolic acidosis, or high lactate levels. So intensive treatments and care include volume substitutions. As Dr. Java was talking about, volume depletion is one of very critical status that we need to care for the patient immediately. So full round of your intravenous infusion is critical, vital. So we have inotrope support, upper load reduction, homotherapy for hypotensive resistance, chronotropic support, amiodarone sedation, and ECMO if it's needed. Now we're going to look at much more focus on the pulmonary hypertensive crisis, ventilation, and early extubation of these children. Postoperatively, there are a rapid and critical increase in pulmonary arterial pressure or pulmonary vascular resistance in certain situations. That is agitation when the infants and children are agitated or having external stimulation such as suctioning and pain. There are some of the issues that we have to look at and be very careful in assessment and immediate treatments postoperatively of these children. Pulmonary functions is affected by a large variety of preoperative, intraoperative, and postoperative factors. For example, preoperative factors can be including pre-existing excessive pulmonary blood flow or pulmonary hypertension. Intraoperative factors can include anaphylaxis or edema or lung trauma. Postoperative factors can include swollen mucosa, for example, SIRS, meaning systematic inflammatory response syndrome, or even like pneumothorax. So when we look at the ventilation of these children, especially also in the face of COVID-19, ventilation is one of the most important things that we have to do and turning the equipment. So volume control ventilation is the ventilation of the choice in every cardiac patient after cardiac surgery. In many ventilators, a setting with a pressure control combination can be chosen, that is PRVC mode, and then followed settings can be suggested for the ventilation treatments, okay? Early extubation. Early extubation is typically defined as extubation either in the operating room or within 6 to 8 hours after surgery, but its use in pediatrics is still polarizing topic, meaning not sure, okay? It was common to leave children intubated for 24 to 48 hours after cardiac surgery to assure adequate hemodynamics. There are many advantages of early extubation, including earlier initiation of oral feedings, mobilization, avoidance of laryngeal spasm, tracheal trauma, accidental extubation, oversedation, ventilator-associated infection, suctioning-induced pulmonary hypertensive crisis, mucus plugging, or unfavorable cardiopulmonary interactions. So what do we do with infection prophylaxis? Cardiopulmonary bypass reduces the capacity of the immune system to act against bacterial infections. And so postoperative antibiotics prophylaxis is always given for children after cardiac surgery. So first or second generation of cephalosporin are used or recommended. For an uncomplicated postoperative course, many centers carry out antibiotic prophylaxis for 2 to 3 days, although hardly any evidence-based data for this procedure that is available nowadays. Antibiotic prophylaxis is then continued for 24 hours post-chest closure or ECMO removal. When children are undergoing cardiac surgery, they are unique in both clinical severity or hemodynamics responses to painful stimuli. Using adequate sedation and analgesia into the immediate postoperative period are important to improve the outcome without complicating postoperative care. Intraoperative administration of dexmedetomidine has been shown to be good in children postoperatively, including lower incidence of acute kidney injury, lower stress response, and lower risk of delirium. Unfortunately, today, with a limited time, I can't actually talk too much about acute kidney injury today. So the initial pain management and strategy is influenced by the intraoperative parameters such as duration of cardiopulmonary bypass, total circulatory arrest, and aortic cross-clamp time, the patient's hemodynamic parameters, and timing of the planned extubation. So morphine, fentanyl, and dexmedetomidine or benzodiazepine can be administered intravenously continuously in the initial postoperative period. Children 1 to 6 months old need higher doses of morphine to achieve plasma concentrations comparable to that in older children. Pediatric patients with renal dysfunction receiving morphine therapy are at increased risk of developing opioid toxicity due to accumulation of morphine metabolites. So intravenous fentanyl infusion is useful in children at risk of postoperative pulmonary hypertensive crisis, arrhythmia such as junctional ectopic tachycardia, or continued postoperative bleeding. Dexmedetomidine children treated with dexmedetomidine require less rescue analgesia. In addition to the analgesic sparing properties, it can significantly reduce the heart rate and stabilize the blood pressure at the time of surgical stimulation. Grounded and systematic stress response significantly reduce the length of the mechanical ventilations and reduce the risk of agitation, delirium following the cardiac surgery. So lactate levels should be checked as a routine base. Key to adequate pain management in assessing its presence and severity, identifying those who require intervention, and appreciating the treatment efficacy. Now we look at the nutrition and postoperative glycemic control of the children in this population. The challenge of enteral feeding remains a focus in the management of postoperative neonates with cardiovascular disease. Malnutrition is a common problem in postoperative cardiac surgery of the children, which represents between 15% to 50%. The critical care literature has shown that decreased infectious complications and length of hospital stay in children who were given enteral nutrition early. In a postoperative cardiac patient, normal growth is associated with improved operative and long-term outcomes. Total parenteral nutrition is typically required to achieve adequate caloric intake in the immediate postoperative period, with all of its inherent complications. Children having adequate systematic cardiac output with low serum lactate, good urine output, and normal distal perfusion should have enteral feedings initiated and advanced with close monitoring for any change in vital signs. Increasing abdominal circumferences and emesis prompt evaluation should be taken for feeding intolerance. Feeds can be advanced in those infants who tolerate feeds without concerning findings. These are the postoperative feeding algorithm, which I find is very useful, and you can have a look at whether with the initial feedings and options as well, and how does the infants and child actually tolerate or not tolerate. And then when you look at, so what do you actually assess? You actually have to assess their feeding mechanisms, respiratory status, and also changing cardiac output or perfusion. Then that is your assessment. Based on that, then you can continue with your nutrition feedings. Many neonates have difficulty with oral feeding, in particular those with heart disease. This may be due to gastroesophageal reflux, symptomatic vocal cord dysfunction, uncoordinated suction and swallow, etc. Postoperative glycemic control is that when we look at the hyperglycemia is frequently encountered in a cardiac intensive care unit in the postoperative neonates and child, with the study reporting incidence as high as 90%. In the first 48 hours after surgery, hypoglycememia may occur, especially in newborns and infants under 3 months of age. Therefore, these patients usually measure their blood glucose twice a day. In order to prevent hypoglycemia, a 10% aqueous glucose solution can be infused. Improving communication with the families of patients undergoing pediatric cardiac care or even in a pediatric intensive care unit is the key. Listening to the family's perspectives is important to improve the clinical decision making and also patient outcomes, even the family satisfaction and understanding as well. So family-centered rounds can improve family confidence and trust among the healthcare team. So 4 very important dimensions: patient and family-centered relationship, sources of locus control, help them to feel that they are in control, especially for the parents and the families. Barrier of communication need to be prevented and need to be actually trying to get some intervened. An opportunity for process improvement is also important, such as video presentation, written information, having a schedule, a tour of the PICU prior to the surgery, and being introduced to PICU staff that can be very good, and it will show such a caring attitudes to the parents. Now, because I was talking about the improving the communications with the families, and so now I'm going to show a little bit. I only have 3 minutes left. I'm going to show a little bit about my telehealth in special children and the family. This is my research experiences in using the online support forum to support the families and children depending on home oxygen. Can be non-invasive oxygen or can be via the tracheostomy home oxygen. So in my past few years, I have tried to, as I said, using a qualitative study and to find the themes and categories that are important for the primary caregivers looking after children who with the tracheostomy at home. So they so they have to learn about or try to move the ventilators back to their home, and then I want to know what is their needs and what their concerns are. So then after I developed my qualitative things, then I started using some of the existing surveys to look at the parental stress levels, uncertainty, and to look at their satisfaction as well, and what kind of social support they actually needed. After that, I have found that just what our COVID-19 pandemics nowadays, we need information and quick and easy and easily accessible. So I developed trying to develop an online support forum, putting a lot of information for them and information they need. And I also try to include app, and app can be helpful because a lot of children would need to go to the hospital for venipuncture or blood taking, and they would be very stressful. So I want to understand how this app can help the children about age 3 above, okay, and that when they look at the app, would that actually reduce their anxiety and their fear. And I also from my online support forum, as I say, I develop videos for the procedures and skills that we actually learn as a nurse in our hospitals and in our education settings, and help them to be able to watch the video again and again, and at any time with the procedures and skills that they need to know. Currently, I also and I have also developing a short video with my research students to help parents who actually bring their sick infants to the NICU setting, and especially about the emissions knowledge and questions they might have. We're using online video as well. I also have worked with the US psychological in children teams, translated into this parents education in Chinese, and we translated in this animation is wonderful. I probably have to show you maybe next time. It actually helped to parents to understand about their children, and to help improve their relationship between child and their parents as well. So telehealth, I actually have 222 electronic files in these 7 childcare topics about caring of younger children. When my baby is sick, what do I do? What's wrong with my baby's breathing? When my baby is a premature infant, what should I look for? Especially also for the newborn care, much more usual newborn care, that I also have some topics for them, and also the things that should be aware when feeding the babies, and the things I should be aware when having vaccination as well. with this online forum, I think one of very important function is the group chat board. You can actually networking and connecting between professional and also parents, other parents as well. So family support networking is one of informal support systems that I think the parents loves very much. So these are my reference that I have used for today's presentation. And these are my research publications that I have published over the years, but much more focused because there are others publication, but I think this publication is much more related to my topics today. And thank you very much for your attention. Any comments and suggestions, questions, and this is my emails. And I know I've got 2 minutes over. Sorry about that.
Thank you so much. Thank you so much, Professor Wang. Your presentation is really amazing, and I think your research actually cover a lot of the different medical issues. I think including the low cardiac output and arrhythmia, and also about the pulmonary function, infection, and also the sedation, about the pain management, also nutrition. And I think it's something more than my expectation is that you are not taking care of the physical issue, also like the communication, the mental issue, and also the telehealth, which is quite related to our research center's focus, like telehealth things. So I think now I want to open the floor for questions. I think those being mentioned by you could be also open for the research cooperation with the UNKT. So I think this is gonna be good for our mutual cooperation. Thank you so much. And so now the time is for yours about the question. I think better that the people to ask first for your section, then because until 3, I think we still have a bit time, so we can just have the QA section first. Is it okay?
It's up to the audience.
Yes.
If you want to write your questions in the comment section, and
Yes.
then we can actually go along with the Lucas. I think maybe Lucas want to do his presentation first, and then we can
okay.
collect all the questions in the end, including for
okay.
Dr. Java.
Okay.
Dr. Java will also come back
Yes.
to see you all. Is that all right, Jason?
Yeah,
so
sure.
We might
Then
let
I
Lucas.
will leave my own questions in the end.
Thank you.
Okay, thank you. Thank you. So then we now proceed for the next speaker. Okay, so the next speaker from our side is Dr. Lucas, and now I would like to have a short introduction for Dr. Lucas. And I think Lucas, perhaps some of you already know him. I think now Dr. Lucas, Dr. Adi Lucas Kurniawan, he is a researcher at National Taipei University of Nursing and Health Science, actually working in our research center. So he's my colleague, and he's quite outstanding for the data science, big data, and his research mainly focus on the public health, epidemiology, nutrition, which mainly focus on dietary pattern, male reproductive function, and iron metabolism in the human health, and to predict the disease prevention. So so now I would like to invite Dr. Lucas to have his presentation. Now, Dr. Lucas, the time is yours. Thank you.
Thank you, Jason. So everybody can hear me, right? It's clearly. So I would like to share my screen first. But I guess because I'm not the co-host yet, so yeah, okay, now it's okay. So everybody can see my screen. First of all, I would like to say thank you very much for UMKT and NTU-NHS that for having me to a little bit share about my research and have some idea about the potential research collaboration with the UMKT. And in the first slide, I would like to first introduce about myself. So as you can see in here that I'm experienced in the doing big data mining analysis, which is related to the eating habit and dietary patterns to predict the human health, and as well as the non-communicable disease prevention. So a little bit about my background. So I graduated from Indonesia, from Brawijaya University in 2014. And then after that, I continue my master and PhD in Taiwan. And then after I graduate from PhD, I directly continue as my journey, as an academic journey, as a researcher in National Taipei University and Nursing and Health Sciences. A little bit about my expertise and research interests. So I'm mostly interested in the nutrition and human health, as well as also CKD or chronic kidney disease, as well as the iron metabolism, male reproductive function, and as well as the big data analysis. So basically what I did, so this is the research area that as summarized that what I did, is I used the big data that have been collected from health survey or health screening, which have been collected for a long period of time. And then from this big data, I simply do the lifestyle behavior analysis. The lifestyle behavior analysis in here is including like food diet analysis or other lifestyle related behavior in the human. And then with what kind of analysis that I use is usually mainly I use like a kind of regression, which is a reduced rank. And some of the analysis I use the AI or artificial intelligence, which mainly focus on the machine learning. And from this analysis, and I collected the previous literature related to the biomarkers of the disease, I can predict or do a precise prediction about the food or other factor that associated with the disease. So from this kind of analysis, we can precisely predict like what kind of food or what kind of factor that associated with the disease relationship. And then we can link it to the our disease of the interest of the study. For example, like a cancer, we can link it to the cancer, or currently I'm interested in the mental health, or we can link it to the disease like a low male hormone, sexual hormone function, or we can link it to the people who have overload iron syndrome, or also we can link it to other cardiometabolic disease or other non-communicable disease such as kidney or liver disease. So a little bit about the kind of machine learning that I did. So actually machine learning is a part of the artificial intelligence. Like, so artificial intelligence means that we do analysis which is mimicking the intelligence of the human, like that. And so part of the artificial intelligence, we have a machine learning and we have a deep learning. So there is a part of what kind of analysis that I sometimes use for the machine learning. And from this analysis with the machine learning, we can have a kind of precise prediction of the disease or health related issue. So a little bit background about what kind of things that I do mostly is mostly about the dietary pattern analysis. Why I interesting on this? Because as we know that humans consume a food which is contain the nutrient, it's in the synergic combination. And I got this pattern, it's usually from the survey or health survey or dietary assessment survey. And usually the survey will ask the people who participate in the survey about their food that they eat one day before, or like a questionnaire about like what kind of food they eat like 3 months before or 1 month before, kind of like that. So what's the definition about dietary pattern is mostly about the quantities or proportion or variety and combination about the different foods and drinks which is we frequently consume, like habitually consume. And with this kind of pattern, we can formulate a new dietary recommendation, and we can also have a comprehensive understanding about diet and disease relationship. So there are two kind of analysis to do the diet pattern. First is the by priori or previous knowledge, and then the second is the by posteriori, or usually is a data-driven knowledge. And mostly that I always use is about the reduced rank regression, or we can abbreviate it as RRR, which is combined with between the prior knowledge and also data, or like data that we have from the health survey, something like that. So a little bit about the RRR. So basically RRR is same, little bit same with the multivariate linear regression, where we can combine the predictor. So if we have any variable that can predict the disease of interest, and then we can link all those predictor with the response. And this response mainly is focused on the biomarker, which also associated with the disease of interest, or other nutrients, which is also maybe linked to the disease of interest. So as we see that the response is mainly we take from the previous knowledge, which is a priori part, and the predictor, which is the data that I have, that we have from the health survey, which is a posteriori part. So that's why the RRR is a kind of a precise, can generate a hypothesis which is more precise about which factor are related to this specific disease of interest. So this is a little bit about my kind of publication. So we can see that here I mostly publish about diet related to the health disease, like testosterone level, diet about the chronic kidney disease and cardiovascular risk factor, and also several health behavior or lifestyle behavior like sleep duration or insomnia, and physical activity like regular walking and drinking water in the type 2 diabetes patient, and then dietary pattern with the anemia and dyslipidemia, and also again about the testosterone or male sex hormone, and also about the unhealthy lifestyle behavior in the male sex hormone, and also a lifestyle in the anemia, and as well as the education part in the cardiovascular risk factor among CKD patients. So next, I would like to share the idea for me that I have been interested for so long for this collaboration time. So I currently I'm interested in to see the mental health, especially for and also food literacy and dietary changes among unhospitalized COVID-19 positive people with or without comorbidities. Because as we know that the COVID nowadays can change the people who has confirmed that they are positive can change their mental health. And as we know that mental health is very important part of our life, because it's a very important. So the thing that I'm thinking is we can conduct online survey about mental health or food literacy and dietary behavior. And after we gather the data, we can use the machine learning algorithm, and hopefully we can gather a data from both countries, like from Indonesia and hopefully from Taiwan as well. And then we can compare like what is the factor that associated with their mental health from the people who is self-isolate, which it's not required to hospitalize like that. And as we know that the prevalence of the coronavirus in Indonesia is also sharply peaked, and in Taiwan in the current more than 2 months is also peak as well. So hopefully we can gather the participant and to see what kind of factor that can change their mental health or food literacy like that. Because I very interesting on the mental health, because there is a research in the United States that the COVID-19 pandemic and the resulting its result in economic and social recession, it's have a negatively affect many people's mental health. As you can see in this figure, this is between January till June 2019 versus January 2020. And as you can see in here that they reported that 4 in 10 adults in the United States, it's reported that they have a symptom of anxiety or depressive disorder. And then if we break down this symptom, we can see that like around 35.8% they have a symptom of anxiety itself, and around 28% is they have a symptom about depressive disorder itself, like that. And then if we see the next slide, it's mostly the young adults age have experienced the highest number of pandemic-related consequences regarding their mental health. They reported that like a closures of university or office, and lack of social activities, separation from family and partner also, and also loss of income contribute to the poor mental health of the young adults aged from 18 to 24. Okay. So this is a little bit a background about like why I interested in the currently I'm interested in the mental health. And then a little bit about the food literacy. So actually the food literacy is the definition is like a set of skill or like a factor or attributes that help people in preparation of healthy and affordable meals. So food literacy is an essential life skill. So it's have a 5 factor. So it's a food skill and required some knowledge. And also it's required like a external support such as a food environment, learning opportunities, living condition, and social cultural environment. And also it's also required a knowledge, preparation skill, and experience, and then self-efficacy and confidence as well, which is part of the mental health. And also food and nutrition knowledge, as I mentioned, and food decision, like ability to budget, plan meals, and then also shop for food. So this study mentioned that there are a barrier of the food literacy. So what is the barrier of the food literacy? It's social isolation, depression, stress, and lack of self-esteem. That's which is these 3 is a part of the mental health, which can change the behavior of the food literacy in the human. And then there is a previous paper that I really interesting, and this paper have a title that there is an impact of the COVID-19 pandemic on the diet-related lifestyle behavior. And this is a Google Trend analysis. So the researcher analyzed from the Google Trend searching engine. And the result is very interesting. So from June 2019 until April 2020, people have an increased interest in to see or to search keyword related to the food insecurity. So they mostly focus on the food banks or free food or free meal or food shortage like that. And then also, as we can see also in April 2020, their interest to eat in the restaurant is decreasing, mainly because of the lockdown and etc. And then next figure is see that increased interest when they use a Google engine, search engine. There is an increased interest of a keyword related to the vitamin. Mostly is a vitamin C, as we know that vitamin C is important for the immune system, something like that. And also, lesser extent, they also increase the keyword or searching about like herbs, like a garlic, ginger, or turmeric, something like that. And they also found that which country is usually mostly search about the vitamin C. And if you can see that Asian, like a Philippines, Malaysia, Indonesia, it's more likely to search about the vitamin C and the coronavirus. And also European, Hungary, United Kingdom, Germany, Ireland, Norway, they mostly interesting to search about the coronavirus and vitamin D, which is vitamin D is also part of our immune system. And then like a Central or South America and Caribbean country, mostly related to the zinc and coronavirus. So as you can see in here, how like a pandemic can change the knowledge of the people and the interest to change their behavior by searching about more healthy food that related to the immune system. And then they also found that the daily confirmed COVID-19 is significantly positive related to search keyword related to the food security, like dietary behavior, immune related nutrients, herbs, and food, and also indoor lifestyle behavior like a plant, flower, and meditation. And however, daily confirmed COVID-19 cases is also inversely correlated with the outdoor activities, like in this red line, like restaurant, and then cinema, gym, hotel, park, resort, fitness, something like that. So as you can see from this research, it's very interesting that dietary habits during self-isolation or during a lockdown, it can change, and also its influence in the later life. Like that. So what I'm thinking that we can do is like, because COVID-19, like how COVID-19 can change the mental health of the people. And then this mental health can influence the food literacy and dietary habits or other habits during self-isolation or during lockdown. And then we can have a collaboration, for example, like generating online questionnaire survey, like what kind of factor that may become a predictor of the mental health, or a questionnaire or survey about mental health itself and food literacy itself. And also we can recruit of the participants, hopefully from both countries. And then we can have data management and analysis. And finally, we can publish this research. Okay, so far that's from my presentation. So thank you very much. And we can start for open discussion if you are interested in this topic and maybe have some idea to add related to the mental health among COVID-19 patient, or maybe any other idea from the nursing side. So thank you, and I will give back to
Okay,
Jason.
thank you so much. Thank you so much, Dr. Lucas, and your presentation is really nice, really amazing, and I think about the nutrition issues regarding the COVID-19 prevention and recovery should be one of the most hot topic at this moment. And you also list from a different area of the world. We have like a different eating habit, and might have some different tendency for the supplement. And I think vitamin C, vitamin D, zinc, garlic could be a very nice potentially prevention for COVID-19. So now I think it's about the time for the question. So so all of you, all the audience are welcome to, are all invited to ask the questions. You are welcome to, if you have any things want to ask these two presenters. And later we will also keep a time for Dr. Javad, because in the morning section, I think there's still some unanswered questions for Javad, and Javad might also answer this question. And also, if you like to ask question, you can just leave your text in the Zoom software here on the right side, and I think all the speakers will answer the question according to your question. Okay, thank you.
Can I follow on Dean Nun's questions about the how to prepare the psychological impacts of this family who might have children having breathing difficulty? Is that right, Dean Nun? Yeah, I think it's a wonderful wonderful questions and great questions to ask, because in this phase of COVID-19, we are also seeing children being infected, especially the Delta variants. Like now the Australia, US, I'm not sure about from the Indonesia. I would like to actually know about what happened in Indonesia at the moment. With children having difficulty in breathing, especially they are not actually being vaccinated. When we are looking, in my research, I have found that the parents are so worried and anxious when children can't breathe properly. This is the first symptoms that they're really concerned. Rather than fever, we can see a lot of children having fever. But when children having difficulty in breathing, that means their hemodynamic status is already in the critical moment. Unlike adults, when you are having difficulty breathing, your lung expansion, your diaphragm are still mature enough to actually combat this virus. But in children, it's different story. Their lung is not being able to maturely enough to expand. So when they are infected with the COVID-19 variants, they start getting difficulty breathing. They can get very tired, fragile, and the parents worry so much about that. So I think it's important to tell the parents, especially in this phase of COVID-19, that how to assess when your child is not well. It doesn't have to be, when your child actually have breathing difficulty, the symptoms, and then you start to think, oh my God, you have to go to the hospital now, and the hospital bed is full, and hospital are so infectious. I don't want to get my other children to get infected. So it's important to tell small signs, how to assess their children, especially they have a little bit of fever, they're not eating well, drinking well, then you start to be aware, tell the parents that still aware that your child is not well. Then do something about it. Having home oxygen. Usually we, at the moment in Taiwan, we want all the patients when they are self-quarantine to measure their oxygen saturations. So we are at the moment in the IT tips. We are trying to make sensors using phone to actually help the patient to sense their oxygen saturations. So you need to, because unlike adults, when we have difficulty breathing, our saturation won't get down so quickly. But when with the children, when they still be running around, and going outside to play, but they already have breathing difficulty. Once they actually exacerbated with their home oxygen saturation, it's too low. Can be lower than 80%, which is not good. So I think teach the parents nowadays, it's very important. So great questions, Dean Nunun. Thank you for that.
Thank you very much. This concern about first symptom, right? Like fever, short breaths, or we using pulse oximetry, right?
You can using the home saturation. We are inventing in Taiwan at the moment using the phone to sense the home oxygen saturation. So maybe some other time we can share that. At the moment, a lot of hospital at the moment, a lot of doctors at the moment, and also working with the healthcare team, we start doing that. Otherwise, we can't cope with all the patients who are self-quarantine, especially the children. And we are getting the children go back to their school very soon. We are all very concerned. They are not yet vaccinated. What about the children in Indonesia? Can you share something about that with me?
No, I don't have the data yet.
Do they have, like, in a news report, are they seeing children being infected and having difficulty breathing? Now, the more cases now? Not sure.
Mrs. Wayan? Maybe since Mrs. Wayan or Mrs. Fatma as the pediatric
department.
Department.
It's okay. We can share with that some other, later. I have also want to answer questions to Imama, who also actually raised questions about the telehealth, okay, and how to encourage the family to use them. When we use telehealth or like using iPad or phone, they should be able to access internet. I know a lot of internet access in Indonesia is usually quite okay. So using this, because usually parents want to see the doctors, nurses face to face. But because the COVID-19 pandemics, nowadays we learn that telehealth is important. So to protect ourselves, protect others. So sometimes to make it easy to use, having internet access, having mobile phone, having computer at home, with all the video, all that stuff, it's important. But because a phone, including the video, include the camera, including the sound already, so phone usually are quite easily accessible for the parents to use. But then what happened with the other side of the hospital section? Then you need to establish a platform. Putting your information, like I designed some electronic file, but they don't usually like to read things. They like to hear and watch videos. So then we start to use short videos. And even that I wanted to improve the parent-child relationship as well. So there's a lot of ways to encourage the parents to use phone, to understand, to talk to the healthcare professionals. And so it has to be both sides. It has to be bilaterally ready to get the telehealth, established. So I think it's great that we start to do now because of COVID-19 pandemic. So I think all my questions being answered. I also answered Jason's questions already. So I'm going to leave the rest of time for Lucas. Is Lucas online?
Okay, thank you.
Java is online. Does anybody have any other questions? Yeah. Okay.
So
now, Din Noon, you need to exercise at home. Yeah. To increase your breathing. You have to increase your breathing. Yes, deep breathing, because you are still coughing. I can hear that. So you need to have a lot of deep breathing, and also some lower leg exercise. So you actually have your heart pumping. That means that you are actually clearing your lung, because in your lung, from your coughing, I hear you have mucus in your lung. So you need to get the mucus out. If you don't get the mucus out, just like we are having chronic lung disease in children, they need to get their deep breathing. So in children, we will use blow the bubbles or blow the balloon, and even we use any color paper and blower as well to do the competition exercise, so that they find it not interesting. So they're always the winner. The children always the winner when we do the competition, and I'm the loser. And they're always, well, okay, I can win you, and then we do the exercise together. So that's how you actually look after children, because they need the needs of playing is the essential thing for them to do whatever you want them to do. So that's about pediatric nursing. So didn't you know you have to exercise?
Yeah. Okay.
Professor
All
Wang.
right then.
Yeah, Professor Wang.
Lucas.
Professor Wang, before you give to Lucas, I would like to mention please still read the column, and if you still can answer some several questions that is coming, then you can answer later after Lucas session. I will just remain to see the column. Okay, you can give.
Java, ask me a question. Java. All right, then I can answer the Java's questions a bit later, but I know there's a lot of answers for Dr. Java and also Lucas. So who is going to answer, try to respond to the participants' questions now?
Maybe I will answer some of the questions. First is from Imama. And Imama asks about like what kind of idea that can be used in the nursing research to conduct related to the big data, because since limited data about nursing like that. So if you basically the big data is consists like a lot of data, but mostly it's related to the like a health survey or health screening, but actually it can be also used for the nursing research area. So for example, if there is a big data about the occupational health, it's also part of the nursing, which like an occupational nursing side. Or for example, there is a data or like health screening or health survey data, which have been collected for several years about like people in the home care, or people who is in the elderly, in the community dwelling elderly. It can also be used for the research as well. But most my understanding is mostly the big data is related to the public kind of a public health. So we can see that we can like search about like what kind of public health nursing usually do like in that area, and can link to the what kind of the research question that they can found from the data, especially the big data. We can also link to the like a lifestyle or care management, as I mentioned before, like some big data also content also part of the lifestyle or mental health, which is also can be part of the public health nursing as well. That's from me. And then the next question is I'm not sure the name because it's only half. Asks about like whether there is any impact on the herbs consumption on the COVID-19 patient during recovery phase, because in Indonesia many people consume herbs. So we as we know that there are many kind of herbs. So, but we need to specialize like which kind of herbs can help or can boost the immune system, like that. The many research show that like a zinc or like herbs that contain zinc, like a turmeric, ginger, because it's contains zinc, and also like a garlic as well. It can help recovery phase to recover your immune system, because after when you get the infection, the immune system fighting so hard to kill the infection like that. So when you are in the recovery phase, you need to recover your immune system by boosting that, and one way to boost that is from the food that you eat, like rich food that rich in the like antioxidant or immune rich food like that, so which can help to boost your immune system like that. So that's I guess all the
Dr.
question.
Lucas.
Yeah, yes.
Dr. Lucas, talk about herb. You may remember jamu. You know jamu.
Yeah.
Jamu. The bitter one is sambiloto. Several people use jamu sambiloto. It's recover 5 days.
Thank you for adding that, but because I'm not really sure about what the content of in that herb, but thank you for adding that kind of information. But I know like traditional Indonesian drinking, like a jamu, content like they made it from several herbs like a ginger, turmeric, or I'm not sure what is the English of kunyit. Yeah. And so that's kind of herb also contain like zinc and other minerals which can boost the immune system during recovery phase. So that's all from me. So I give back to maybe.
Sorry, Dr. Lucas.
Oh yes.
I need to ask again about the herb that in the Indonesia drink too. What about the dose? I mean, how much we must drink the herb? It's also in your area research?
About the herbs, actually there is like a daily intake of the herbs. Like for example, like herbs that contain zinc. So we need to know like what is the upper level of the zinc that we can intake in our body. So for the upper level of adult zinc is around like 40 milligram per day. Say 40 milligram per day, or like so the recommendation, that's the upper level. For the recommendation, it's usually around 8 milligram for women, and because men have more metabolism than women, so they required like higher, like around 11 milligram. But for like vitamin C, it's also that kind of vitamin that boosts the immune system. So actually, if you are not really sick, it's not necessary to drink like 1,000 milligram of vitamin C, because actually our body only need like around 90 or 120 milligram. So that's the like a daily recommendation like that. So and everything that we eat or we take too much is sometimes have a bad effect, something like that. So that's from my answer.
Thank you, Dr. Lucas.
So I also want to add some information about my part. So if there is more question, you can also ask. And I wanted to talk a little bit about pain, because there were some questions about like pain in COVID-19 situation. And the other one was about the cytokine storm. So about the pain and the differential diagnosis of pain. So the pain can be misleading. My voice is clear, right? If the moderator
Yes,
hear
yes,
me.
the voice is
Okay,
fine.
okay.
The
I was
voice is
just making sure that you can hear me. I'm not talking
Yes,
to
yes.
myself. So the the pain can be misleading and can be of different diagnosis. So it can be panic attack, it can be heart attack, or it could be COVID symptom, because one of the COVID symptom is pain, and especially chest pain. So when the pain exists in the chest area, so it can be like frightening for the patient and say, oh, my heart has some problems. But because indigestion also can cause heartburn. Heartburn is like for the esophagus pain. So it's very important to see the other symptoms that accompany that pain. So for example, if the generalized anxiety disorder, if the patient has GAD, so it can be more in favor of the anxiety disorder, this pain. If the patient is OCD already, so you can be like, you can doubt the pain if it's like the cardiac related pain. If the patient is has any anxiety, any social, any kind of behavior like that, or had already experienced some panic attack. So you can simply ask like a medical history from the patient. If he or she is already taking some medication psychologically related, so you can have some doubts about this pain, and the more evaluation is like about the heart disease, like less favorable. So if you want to know if the panic attack caused the pain, so recruiting panic attacks and fear of having another attack to the point where it interferes with everyday life is very important. And it's very important to know 2 to 3% of US adults have been diagnosed annually of panic attacks. So it's very common, and it's not something that you never see in your professional life. So be aware of that. Panic attack affects women more than men. So if some men came with like a sharp pain in the chest, be more act as more seriously as you can compared to women. A person can develop panic disorder for the first time in the setting of COVID-19 stress if specific criteria is met. For example, if symptoms persist for at least 1 month and maladaptive change of behavior, or having 1 month of persistent fear about having another panic attack. So we can have it like for the first time. And panic attack is like happening for the first time for like a patient during this COVID pandemic is not very likely. So if some sharp pain came in somebody that had never had panic attack, so panic attack is out of order, is out of picture, and we can think about other causes. So heart attack pain, if I want to like explain a little bit more about that, it usually accompanies with shortness of breath, dizziness, crushing chest pain, that the pain is so much that the patient might remember it as the most painful experience of his or her life. But symptoms can also differ from person to person. I also noticed that most of these attacks go to the left arm, so it also can be one of the diagnostic checkpoints that you can just check. And the COVID-19 chest pain would most likely to have accompanying signs of upper respiratory infection, like coughing, phlegm, or sneezing or other things. So if a patient is asymptomatic, so it can be more like a heart attack. Heart attack is also very common. So there is no reason to underdiagnose this during this pandemic. Somebody come to the hospital and like saying that, oh, I have like chest pain. I said, no, it's gonna be all right. It's just COVID. It's your COVID. The patient can have COVID and also like exacerbate the condition and having the heart attack at the same time. So we should be very careful about these kind of patients. I hope that I answered this question about like pain, cover that area. The other question was about like the cytokine storm. So our body is making cytokines to fight against any viral or any like kind of inflammation in the body. So cytokines are not bad in nature, and but if there is a lot of the large amount of cytokines in the bloodstream, so it can cause some issue that called cytokine storm. But dealing with cytokine storm is very difficult, because if we want to suppress the immune system of the patient, so we are also taking away the only defense of the patient against the virus. So we should be very careful about this, and about the medications that can cover this cytokine storm. We can name some medications like tocilizumab or other kind of JAK inhibitors, but all of them should be prescribed by care, and it needs more care of the health personnel in the hospital. So we should be aware of that kind of situation, but we shouldn't like overestimate the nature, because the nature of the cytokine is not bad in itself. So if more question, I can also like refer some papers about this area of cytokine storm, and I can send it to the chat room. If I think to everyone I will send it, so the somebody that asked this question can have some more readings.
Okay. Okay. Thank you so much. Thank you so much, Dr. Javad. And so I think there will be some new questions for Professor Wang, maybe. I think there's several.
I have answered them all, but I just want to follow on what Dr. Java was talking about pain. I think pain is an experience very personally. So some people are tolerating their pain, with a high level. Some people can't. So especially in children as well, we wanted to make sure some children can tolerate their pain pretty high. They can tolerate quite well. They don't actually express it to you. And that can be an issue. Similarly with cardiac angina pain, I'm not sure about, maybe I should ask Dr. Java about this. Angina pain, it's also kind of pain that actually experiences for MI. Nowadays, we have this COVID-19, a lot of people have severe chest pain and can be mild chest pain as well. So all these symptoms, especially in the lung and heart area, also including the tummy, your abdominal, like vomiting and diarrhea also as well. So all these symptoms need to be, taught your patients about that, or even with the people who are self-quarantined, what do they actually look for? And so signs and symptoms for assessment is the key. Now, do I have more questions? I think I have answered them all. Lucas, did you have more? So anybody have questions or comments?
So about the pain that is like lower than umbilical line, it's more likely to be like related to the heart, but it's like upper than that, it can be. But the thing is that even experienced physicians can just misdiagnose the even the heart attack or ACS pain, especially when they have, for example, just consider like a physician or a nurse that has been visited maybe 100 COVID-19 patients with a lot of symptoms like chest pain, and all of them are related to COVID. And suddenly it's like a patient comes also with COVID. And he also tell the doctor, oh, I have a chest pain. And the doctor says, oh, it's because he already like diagnosed a lot of COVID without heart attack or without any heart involvement, without ACS. And he says that he will misdiagnose it very, very easily. But it's always good to like consider the patient to be cardiovascular disease unless it is proven otherwise. But it's also controversial because we cannot like send a lot of patients to like evaluate or be hospitalized in this situation. So the decision is very critical, and it depends on a lot of things, and it is really important for the doctors and nurses to be fully aware and fully alert to everything. So here comes the health of the nurses and physicians themselves. So they should be healthy in the best condition, and they should be alert. So like long shifts for doctors and nurses is like not only bad for themselves, it's also bad for the patient.
I agree. All the nurses and doctors working in the first line with caring for COVID-19 patients or potential COVID-19 patients, long working shifts can get you very tired, and you can miss out your own chest tightness because you are tired from your working and caring for the COVID-19 patient, because it's a long hours of shifts. So I think it's also important for the nurses and the doctors to watch out their own symptoms, signs and symptoms, because usually we miss out that so much because we just think, oh, I'm just tired because it's been a long day. But perhaps you are also having adverse symptoms from potential infected as well. So I think it's important to teach our students, nursing students, and also the nurses in the first line of the hospital, to tell them how you actually assess your own symptoms as well. Okay, do we have more questions, or if not? Or any ideas from staff of UMKT? We have about half an hour Q&A. Thanks for Lucas and Dr. Java, Dr. Lucas as well, for being here with us to answer most of the questions for our friends in UMKT. Now I think we can actually move on. If you have any ideas or research questions for Dr. Lucas or Dr. Java, has been doing a lot of research in this area as well. Like Dr. Lucas doing the big data analysis, which is one of the trend nowadays because I think a lot of information is actually being studied, and we need to actually work with the big data to find the best formula to predict something. And this is also one of the things that being, a lot of people are trying really hard, and a lot of data is being analyzed to give some prediction as well. So I think Dr. Lucas doing this wonderful research as well. So any questions from UMKT or ideas?
Maybe just one more left, Professor. I just in the chat, in the column chat.
For whom?
For you, I think
for
so.
Me? Which is that?
From Fatma. Fatma, I would like
okay.
to ask the question in
One of the effect of pandemic COVID is oxygen set equipment. Yes, I agree, because even with the chest pain or happy hypoxia, you need oxygen. Oxygen is the key for chest pain, and also positioning. Sitting positioning also can help them breathing better. Sometimes if you want, like for chest pain patient, you can help them to lie down, because at that position your oxygen consumption might be the least, during the positioning, like lying positioning. However, it doesn't help with your breathing. So usually sitting upright would be the best to help patient breathing much easier if they have difficulty breathing in terms of symptoms. So oxygen set equipment, that's why in Taiwan, when we had the higher peak of the confirmed cases in May, we act very quickly. We test everybody, all the potential cases, and then because we don't want our hospital to get too much patient, and we already had too much patient during the May of our COVID-19 confirmed cases, but now, like today, we only have numbers of confirmed cases today. For the last week, we only last 2 weeks we only have just few cases of confirmed cases in Taiwan. So our hospital, it's not exploded with patients with COVID-19, and then our medical staff, our nursing staff will get too tired because it's limited in terms of workload. We can't get, it's already burn out in terms of caring for COVID-19 patients. So our oxygen set equipment is such an important oxygen for everybody. It's important. I mean, our pharmacy in Taiwan, it's quite convenient, and it's a lot of pharmacy. People can get help. Only in a Taipei city, New Taipei City as well, we have a lot of hospitals in New Taipei City and Taipei City. However, when we have remote area, much more remote areas in Taiwan, then accessibility to oxygen might be a little bit difficult. So I think oxygen is such a precious thing nowadays. It's important to prevent our population not being infected too severely. Vaccination won't help you not being infected. Vaccination, any kind of vaccination nowadays, COVID-19 vaccinations, only help you to reduce the severity of your illness when you are infected with COVID-19. So everybody should get vaccinated. In fact, just like flu, when we have during the winter time. I know in Indonesia it's always warm, but in Taiwan we have winter time, and then we have flu. People are complying with the mask. So like mask is important, everybody. Mask is important, okay? To help you being not infected when you are close to someone who are actually doesn't is asymptomatic, means there's no symptoms when they're actually infected with COVID-19. So I don't know about Indonesia. I know that it's very hard to get oxygen equipment. We do have enough supply at the moment in Taiwan, but I do think that is the last things people can, because it's so difficult to access patient and people, friends in Indonesia, or friend from what's the city called? Saramandi city?
Samarinda.
Okay. Yeah, Samarinda city. That wearing mask, wash your hands. It's the only things. Vaccination only will help you with your severity of your illness. It doesn't help you prevent from infection. I think I have answered your, is that right?
I think it's okay,
Fatma?
maybe, Professor.
Who is Fatma?
Fatma,
I
you
can't, I don't know your face and your no. I'm sorry about that. Yeah.
Fatma is also focused on pediatric professor.
Oh, great, great. Talk to me then. I need to friends. No, I'm
Yes.
kidding. I mean, I think it's great to make friends from you all on the virtual conference. Yeah.
Yeah.
Okay. Is there any other questions or any ideas
Okay,
from
Professor.
faculty of UMKT?
Yeah, I think maybe the faculty maybe have a short, just short presentation about their idea. Mrs. Ulfa is here, right? Let me
check.
Ufa.
Yeah.
Yes, Ufa.
Okay. Hi, Ufa.
Hello, Professor Wang.
I will. Okay. Can you share your have you already been co-host, Ulfa?
I think no. I'm not a
Wait,
co-host.
wait. Presentasinya yang tadi malam kan ya, Ulfa ya?
Ya.
Oke. Bentar.
Nggak bisa nih dari sini.
Bentar,
I cannot
bentar.
share
sharing.
from here.
Bentar. Pakai yang file. Itu Ulfa, bisa ya?
Yes, but maybe too big.
Oh, too big.
I cannot see all.
Kayak gini? Bisa nggak?
Yes. Okay, thank you very much for Professor Wang and Dr. Lucas and Dr. Javad, also for all Bapak Ibu from UMKT and all from NTU and HS. Thank you for the time. I will share some overview that we already discussed before from the UMKT team member, that at the first time that we have some topics that we will focus on the knowledge on cardiac arrest management and about the telenursing consultations. But however, we try to found some specific data related to the COVID-19 patients who have comorbidity with the heart disease. We have some constraint that we cannot found the specific data about this issue. So that's why we discuss again about the topics or have some idea. There are two our idea that before we already discussed. The first is about the factors influence the success of management in post-COVID-19 self-isolation patient, and factors influence the management in COVID-19 self-isolation patients. Actually, these two topics is a little bit different. For the first is we have idea that we want to explain more. This is the overview of the data that I put here from the latest data that is from the 15 August. Actually, this is yesterday, because our government have update data every day in the official website. for the data from the country, the national, the province, and also in the city. Like we can see here, actually we only can see the big data or in general data like the total confirmed of cases COVID-19, the active cases, and also the total death. However, actually we want to focus on the non-hospitalized or the self-isolation patients who taking care of themselves in their home. Actually, nowadays there is no published data yet that that update the total number or the specific number, how much the patients who self-isolation or non-hospitalized. They only give the total number cases active, even they in hospital or at home or in the center of quarantine that in the government center. And then for the self-isolation and of self-isolation data, we got from other website, like from the non-governmental website, that they cumulative from the sum of reported from the other people reporting the data to their non-governmental organization. So it's actually not the final data, only some data that they cumulative. So it's actually only some, but we can see that from the website of CNN Indonesia, approximately maybe around 20,000 people is self-isolation or non-hospitalized, that maybe they have asymptomatic or have middle symptoms, so that they only have self-isolation at home. Actually, for the national data, there is no published data yet. And also in Samarinda also, we only have from our phenomena in our life, like from our family members, our friends, that many our family and our friends have self-isolation at their home. And then from this case, so many problems that they face, like maybe some have symptoms, maybe need like oxygen, or maybe need some medication or need some vitamins. So that's why next slide, Mrs. Imama. For the first idea, that we want to focus on the variables that related to their knowledge, how they manage their health, or how to care themselves at home, and how about their social support during the self-isolation at home, such as about the psychological, about the nutritional, about the medicine, about the funds, health examination, and also related to the social networking, or like the positive assessment and feeling accepted in a sick condition. For example, maybe one of family member confirmed with the COVID-19 and need to self-isolation because have asymptomatic or middle symptoms, but sometimes they feel like denial, and also they need support from others, especially from family, and also from the maybe from the nurse, from the doctor. It's include for the social support. For example, like other family member or from the friends giving some foods and give to their home in front of their home, and then maybe send some medicine from the doctor, because in Samarinda, every district we have a community health center, and also they will call one by one the patients who confirm with positive COVID-19 and ask them or have tracing, ask them about the who close with them and maybe have some symptoms and ask their condition and try to observe every day from the first day until the latest day, and maybe have some medicine and they will send to them from the community health center to their home. And also nowadays, our government also have like regulation from the community health center need to have home visit to make sure their conditions, like they will checking blood pressure or maybe pulse oximeter also, so make sure their condition is in good. But if have some cases is emergency cases, from the community health center ask them to go directly to the emergency ward in the hospital. This is some overview, and actually we plan for these topics that we want to ask them after recovered. I mean, after they fully recovered and success recover from the COVID-19, and then we will ask that what about their knowledge, about their social support, and also about their spiritual until they become fully recovered. And also we plan that we want to collect the data by Google Form to make our, not have the physical contact, to reduce, the contact of the virus. But this is for the patient who already fully recovered. And for the second one is similar, but for this case is for the patient is still in self-isolation, is around 2 weeks or 14 days, that maybe they still have symptoms. So the difference from these two idea, that for the first is already fully recovered, and then we want to ask them maybe by using them, maybe using some questionnaires about what they did before recovered, and then for this is during the self-isolations. Thank you, maybe from me like this, but maybe from the other team member have any idea or any more informations. Thank you very much, Professor.
Thank you. Thank you, Alpha. Is that right, Alpha? Yeah.
You can call her Ulfa.
Ulfa.
Yes, Ulfa is okay. Thank you,
Yeah.
Professor.
A great outlines of your interest in terms of doing studying with self-quarantine COVID patients. I also want to know that your two research question is more descriptive study, and which is very coherent with what happened now with COVID-19. We don't understand them, so we need to do survey. So some of the important bits I might remind to you that talking about blood pressure or the biomarkers, which is important, but also, with COVID-19, there's a lot of behavioral issue. We need to look at that. And also, like contact tracing. Do they go to do vaccination? How they find about vaccinations? Because vaccination is one of the things very important. Behavioral items, you need to look at that. And also how they look after themselves. What about their family? Does the people have any symptoms? What makes them being honest? See, COVID-19 is very tricky. People are afraid to tell other people that I got infected. And how do you know how to protect yourself and protect others? This is very psychological. I mean, this is a lot of psychological issues in dealing with COVID-19, especially when they are self-quarantined. Are they lonely? Are they depressed? Are they anxious? A lot of have this kind of expertise in terms of mental health. A lot of research now from the Europe and UK, they look, because the numbers of COVID-19 was last year. They look at that a lot of patients when they are namely recovered from COVID-19, but they're actually being depressed. They get very anxious, including children if they are infected. They can't concentrate. They can, they're not happy because the breathing is still difficult. So a lot of things actually affect them long term. So you need to think about your questionnaire. Are you going to ask them about within this month of within the 5 days, what happened to you? That will have different outcomes. When you look at your outcome, you wrote recovered or not. It's not about like that. It's not about recovered or not. You need to look more carefully. What did you want them to become? So your outcome variables or response variables has to relate to your items that you ask. So that also one of the things that I would like to clarify with you, that your items, your factors, might not relate to your outcome variables, or your outcome variables, so it does not actually logically or coherently actually related to your questions. So you probably have to modify with that. Yeah, but I think they are great questions. It's the questions that you are posting at the moment, are so important nowadays. Yeah. Any response from Dr. Lucas or other presenters from our NTU and NHS?
Thank you, Prof. Wang. So I would like to add just a few things. And it's a really interesting topic as well, what the UMKT from the UMKT side that they want to see mainly related to like the behavior or like the self-behavior during among the COVID-19 positive people during the self-isolation. I would like to also add, like, we need to decide like the age group as well, because we need to make sure that the people who join or the participate, it's really can use the Google form, because I know that in Indonesia, it's not, if it's the age gap, it's too big. So sometimes they have more difficulties as well, because they need to click the link and then they need to, like, it's kind of not really simple like if we do it face to face, because if we do it face to face, we are the one who, feel for them like that. And also maybe I want to add like one like a factor as well, like their lifestyle behavior in the past is also affect the what situation they are facing during self-isolation. Like, for example, if they have a past experience for example smoking, and then they know that, oh, this COVID will gonna attack my lung, so they don't need to go to the hospital, but it's also can influence their mental behavior as well. And also like the socio-demographic as well, like they think that, okay, I need to self-isolate, and then it means that I need to, like, for example, 1 month did not go work like that. So it's also affect their like funding as well. They need to think like how they support their family if they still have a burden for that, like that. Yeah.
So, as if there is time, I want to talk a little bit about secondary data analysis for researchers, because there might be some data that students or faculty or nurses, especially nurses that are like now working in the hospitals that are experiencing a lot of COVID-19 patients. So be aware of the situation, and if you have access to data that is like there's a procedure for that, or for example, there's an MRI, there's a CT scan. These data are like can be more valuable and can be more useful. For example, if you have access to like data of CT scan, long CT scan, so you can easily form the study and design a study to evaluate the percentage of people with it's very simple, and it's a percentage of people with long involvement of the COVID-19, even if there are like similar studies before, because this virus is like changing, new variations, Delta variation, other variations are coming every day. So these kind of studies can be of a great value, and can even help the hospitals, can help the government to overcome like this epidemic faster and sooner. So because now the vaccines also came, so the face of this disease changed. So never underestimate the value of secondary data analysis, because hospitals are facing huge numbers and huge data. So you can like a scavenger, you can go and take up those like data that has been treated like garbage in the hospitals, and you can make a diamond out of that garbage. So never underestimate any study, and try to use the data that is already available first. That is like my experience that I wanted to share, especially with the students and like young researchers that just want to start their research. Now is a very good time to go for the data of these like COVID-19 patients, because now journals are accepting new papers and even like simple study designs because of this pandemic. So it's a good time for the researchers to build their career now in this epidemic.
I agree with Dr. Java that
so I finished my part. If there's any question or comments.
I think it's enough, Professor, for Dr. Java, right?
Yeah. Yes, secondary data analysis is the way to do things now, because you don't actually, it's a bit difficult and challenging to do social behavioral study at the moment because of the contact opportunity that you could be infected by some other people. So it's actually a secondary data analysis is a great thing. And in hospital, we have a lot of data that you can actually be able to use them and to form a research question. So which is, yeah. So any questions? So I probably hand it to Imama now.
Yes, I think for discussion this afternoon is enough. I think there is no additional questions. Let me ask them. Din Nunung, is there any additional before?
Maybe we can choose one idea for joint research. I think it's good. Factor influence the success of management in post self-quarantine patient. Just one idea.
Okay. I think for that's the fixed title. Maybe we can have discussion with them later, Din Nunung, for this one. Yeah. For before I mean like for this afternoon session, is there any additional again about our event? Maybe from Din Nunung or Mrs. Siti or Miss Dwi? I think it's enough, right?
I just say thank you for Professor Wang and Dr. Javad and Dr. Lucas about the presentation that we can in the next future join research sustainable joint research.
Yeah.
We're going to rely on Dr. Lucas more now because he can understand Indonesian very well and know about your culture. Dr. Lucas also, a famous person in our university, so he can actually be able to be the key person to link between the joint research, because I think the two research titles are great. Okay, we just modify a little bit. Maybe we can do secondary data analysis. And so there's a lot of things that can big data that can always do the joint research, because I think it's important to study the COVID-19 patient in Indonesia as well. So I think it will be a wonderful joint research, and Dr. Lucas will be able to help us to frame the research questions a little bit more suitable for this COVID-19 pandemic's situation. Okay, but the two questions by UFA, it's great. Okay, so we're going to actually modify a little bit, but it's great questions, and I'm sure we can do more about that.
Okay, Professor.
It's great to see you all.
Yeah, thank you, Professor, for being here. And I think for this session, we will close first. So for all of our audience, we would like to say thank you for your participation until this afternoon session. And we, as the representative of the committee, we would like to say sorry if there is any mistakes during these events. And hopefully we can meet again in the future conference or future agenda. Thank you for all. Yeah, and
best health to do noon. Okay, noon you have to exercise. Okay, okay. Best health to you.
Yeah, thank you for all, and see you again. Yeah.
See ya. Bye bye, everybody.
Thank you, everybody. Bye-bye.
Bye.
Thank you. Bye-bye.
Dr. Lucas look like
Bisa
Korean
dipublikasikan
actor.
dalam bentuk artikel di jurnal yang berindeks Scopus.
Yes.
Bye bye.
Sementara ini yang
Thank you, Prof. Wang. Glad to meet you.
dan jumlah berapa.
Adi,
Tapi bisa
Adi.
juga
The best.
paper-paper yang mendukung
Terima kasih Mbak Imaman.
dan jadi artikel itu bisa saja diterbitkan selain yang utara.
Itu masuk suara.
Memang saya kira itu
Sudah ya Mbak ya?
Sudah, Dek, Ade bisa